All right. Well, welcome everybody. It's 5 minutes after 8, so we pulled it off in 5 minutes that I thought was going to take 2 hours. I apologize. We're not going to be able to go to presenter mode, but we'll work through it. Um, my name's Steve Redquist, paramedic, flight paramedic. Started this endeavor in 1985. Got a real passion for cardiology, for EKG, for more importantly, the whole monitor. And one of the things that we don't do real well with is utilizing that tool to its fullest extent, right? I, we put 4 leads on everybody, right? Everybody gets monitored because we need to see what's going on. We do 12 leads for to look for ST elevation, right? There's a whole lot more information that we can extrapolate from that monitor, from those rhythms, from pulse oximetry, from the waveform, and get a total clinical picture. So today I want to talk about STEMI, STEMI mimics, and STEMI equivalents. And I got to get used to my new teeth here, so and make sure everything's working. So I want to do it kind of in reverse because, we look at the monitor, we look at the 12 lead, we're trained for pattern recognition on the 12 lead and alerting for STEMIs. And so that's what we get wrapped around the axle of. Okay. STEMI is nomenclature that really is kind of old, right? If we think about it, we have these canned statements that we tell patients that just because our 12 lead doesn't show you having a myocardial infarction, you may still be. True. If we read this statement here, so OMI is kind of a new nomenclature that's coming about. I think we're going to see it more over the next few years because what it does, the obstructive myocardial infarction, that term gets all of those STEMI equivalents. Well, there are many STEMI equivalents that we're going to see, and that's the equivalent of an ST elevation MI. Those are the ones that we miss. Those are the ones that we don't alert. Those are the ones that we may not treat appropriately because they haven't had the magic 2 millimeters of ST elevation in limb leads and one, right? So you see where we're going here? This is what I want to get wrapped around the axle of, okay? Because it's where we go. We're not going to have to learn STEMI and STEMI mimics and STEMI equivalents. Well, maybe STEMI mimics, right? Because those are things that look like STEMIs, but they're not, okay? This is profound. I don't want to get into the weeds of the OMI manifesto, but you can certainly Google it and read it at your leisure. And I think it's going to be profound to you as well. So realistically, what we're looking for in a 12 lead is determination of ischemia, infarct, or injury, right? And that's all time dependent. That's all physiology dependent. It's all pathophysiology dependent. It's all time. So what we need under the STEMI protocol is ST segment elevation in 2 contiguous leads. Okay, whether those are limb leads, whether they're precordial leads, we need indication. We need that ST elevation. But more importantly, that has to be accompanied by reciprocation. And reciprocation is essentially the ischemic pattern that we're going to see in the reciprocal leads. So there's a mnemonic called the Pales mnemonic that, because I always had difficulty kind of memorizing. Well, really, is that a reciprocal lead to the ST elevation that I'm seeing? So Pales comes in, and basically the way that it works is elevation in the leads reciprocate changes in the next letter of the mnemonic. Okay, so if you have anterior elevation, you look for inferior reciprocation, and those leads would be reciprocal to the anterior leads. Conversely, if you have inferior elevation, you look for reciprocation in the lateral leads, septal, posterior. And just kind of put a picture of that in your mind. That will help us go through our EKG interpretations as we migrate through the day. So like I said, I'm gonna kind of turn this on its head a little bit. We know STEMIs, right? We're really good at pattern recognition of ST elevation MIs. What we're not so good, what we don't have a good appreciation for, is those equivalent STEMIs. Okay, so we're going to talk about those now. What's a STEMI equivalent? It's an EKG that indicates ischemia and requires really the same urgency in treatment. It's the same interventions, but we don't, as a healthcare system, have a good recognition of those because they don't meet STEMI criteria. They may meet non-STEMI criteria, right? They may meet look weird, but you ask yourself why. Well, it's going to become evident here as we go through this. So, as with anything in medicine, in EMS, we have a magic mnemonic, right, that identifies or helps us identify those equivalent STEMIs. It's called Waldo-ship. So they are Wayland syndrome, AVR segment elevation, left bundle branch block, DeWinter's T waves, out of hospital, return of spontaneous circulation, a subtle inferior or subtle lateral MI, hyperacute T waves, and that isolated posterior MI. Just kind of to circle back because we got wrapped around the axle real early here with technological difficulties. Andra, are you going to monitor the chat for us, or do we need to do that here?
I got it.
Okay. If you guys have any questions, need to stop, need to go over something, just put it in chat or unmute yourself and we'll answer those questions. So once again, Wayland syndrome, AVR, ST segment elevation, left bundle branch block, DeWinter's T waves, out of hospital ROSC, subtle inferior or subtle lateral MI, hyperacute T waves, and isolated posteriors. We'll go through each one of these because these are important. These are equivalent to a STEMI. These require the same treatment and the same procedures as does a STEMI. What they don't meet is a STEMI alert criteria. I think over the next number of years, they'll be added into that. Andra, what are you doing at Anschutz? Are you activating cath labs based upon equivalence?
We are not, but we are discussing it with interventional cardiology, excuse me, when a question comes up.
Gotcha. Okay, cool. So maybe over the next 2 or 3 years, we'll start adding those into our STEMI alert criteria. Hopefully. Okay. So Wayland syndrome. It's Wayland syndrome is kind of a cool little entity, right? It is typically associated with a history of chest pain. So this is that individual who complains of chest pain. Likely when you get there, they are pain-free. You do appropriately do a 12-lead EKG, and these waveforms magically appear. What does that correlate to? It's greater than a 75%, depending upon who you read, greater than a 75% chance of an LAD occlusion. Okay, so also known as the widowmaker. That's a lot of myocardial real estate in that left heart, that left ventricle that is accompanied with this. So I have recently had a Wayland's case and looked down at the monitor, looked down at the 12 lead, and it was kind of like in the back of the ambulance, you hear this, that's my rectal sphincter slamming shut, right? Because I'm like, oh God, this is bad. But then what do? How do I communicate that? Because it doesn't fit STEMI criteria. However, they are actively evolving in a STEMI situation. So what Wayland's is thought to be is a momentary 100% occlusion of the LAD, whether that's a thrombus that has a flap, right? Whether that's a 85% LAD occlusion, and now all of a sudden the patient was exerting themselves, so their myocardial oxygen supply didn't meet the demand, and now they're pain free. But these waveforms, these ischemic waveforms are left over, okay? So 0 or insignificant ST elevation. Insignificant meaning it doesn't meet STEMI alert criteria, okay? So less than that 1 millimeter, but it's still there. Biphasic T waves, specifically in V2 and V3, and then they are typed out, okay? So type A typically is that occurrence right after chest pain, and that will typically evolve into a type B. That is typically throughout the precordials. Most specifically, if we think about lead placement in a unifocal precordial lead of V2 and V3, we're looking at that anterior high septal region that these waves are going to appear. Okay, and we'll talk about the symmetric deep inverted T waves as in type B a little bit more later. There's one important differential when we get into STEMI equivalent versus STEMI imposters. Okay, questions about this? So just another 12 lead that you can actually see, and if I was in presenter mode, I could zoom in. Let me see it. Let me see if I can do this without screwing up. Okay. You can see here in V1 that we're starting to get a biphasic T wave. T wave. We're also looking at kind of some ST elevation, but doesn't meet STEMI criteria in V1 and V2. We see, so that's a type A Wayland's wave. In V3, V4, and arguably V5, we see a type B. So all this is kind of a measurement of the timing of it all. AVR ST segment elevation. I don't remember who it was that coined the term for AVR, but I heard it many years ago called the Rodney Dangerfield lead, right? Because it gets no respect. Well, hey, that's kind of cool. AVR is the only lead that we have that looks even partially at what part of the heart? At the top part, right? It essentially looks at the coronary os, right at the aortic root. Kind of cool, right? We've used AVR to determine lead placement. We've used it to quote unquote determine ventricular tachycardia. And other than that, we don't care about it. Well, here's a problem. AVR elevation in association, we'll talk about it here, in association with the precordial reciprocation has a greater than 75% chance of a left main coronary artery occlusion. But how much? All it. The whole left main. Oh God, we talk about LAD being a widowmaker. This is higher than the LAD, right? So we should probably have respect for this. Okay, so the characteristics that we're looking for is ST segment elevation in AVR with ST depression throughout the entire precordial leads. Okay, so if we see ST segment elevation in AVR, I want to know that there's reciprocation throughout the entire precordial leads. What do you think this patient's doing here? I mean, if you look at this EKG, we have a rate of greater than 100, right? Why are they tachycardic? Because they're compensating for a low flow state in the coronary arteries and lack of oxygen. And now they're getting some hypokinesis, some lack of contraction of the left ventricle, altering cardiac output. And so what do? What is our compensatory mechanism? Increases our heart rate so that we can get more oxygen to A, the coronary vasculature, and B, systemically. At some point in time, we're going to get kind of a diminishing point of return, shall we say, in this, because now we're not getting the oxygen to the myocardium. So we're kind of tacking up here, right? I would expect this patient to have normotensive to maybe a little soft blood pressures until they tank. And then it's AMF yo-yo, right? So this is a very bad EKG to me. So how am I going to call this in, right? Because it doesn't meet STEMI alert criteria, does it? Let me see if I can zoom in on this a little bit. If we look at AVR, well, we've got 1.5 millimeters of ST elevation, but what's contiguous to AVR? Because we got to have it in 2 leads, right? To meet STEMI criteria. What's contiguous? Well, maybe V1, kind of, sort of, but we don't see ST elevation in V1. So therefore, by STEMI criteria, it doesn't meet alert criteria. However, I just said that this is associated with a left main coronary artery occlusion. Oh God. Yeah. Do we have reciprocation in this? Absolutely, all over the place, right? It's not true reciprocation, it's ischemia in V2 through V6. It's reciprocal in AVL. It's reciprocal in 1, right? So it does meet reciprocation. I look at this EKG and go, oh God, I don't like this at all. But how do I communicate that to get a heightened sense of awareness to the receiving facility? That's a question. Absolutely. If I call Dr. Farkas and I go, so Andra, I got this thing. She usually answers my calls sometimes. And I say, you got a really weird presentation here. It's just kind of vague symptomology, a little bit of chest pressure, no real increased work of breathing. They don't look like they're decompensating at this point in time. But here's my EKG. I got 1.5 millimeters of AVR ST elevation, and I've got massive depression throughout the precordial leads. And I've got reciprocation in AVL. But it doesn't meet STEMI criteria, STEMI alert criteria. What do you think? Andra, what would your response be?
Drive faster.
Bingo. Exactly.
All of our providers would see that.
And Eve just made a very valid comment. Not all of our providers would see that, right? And And that is a potential problem, because if you think about STEMI criteria, it's been around since the early 1990s. It is absolutely ingrained in our mind. It's absolutely ingrained in physicians' minds. I work in a very rural setting that we're taking folks to a critical access facility, ER, that is typically staffed by emergency trained PAs and or family practice docs, right? They got a whole lot of other stuff to keep up on in being in family practice and geriatrics and they may not have even literally heard of a STEMI equivalent. What the hell is that? Right? And until you get this case and you go, this is what this is, right? So this can be a very difficult situation. And to change that thought process throughout medicine, right? Getting away from STEMI criterias, adding in the equivalent criterias, because we just listed what, 9 equivalents, and those are the things that we're missing.
Would assessment pearls help you with that?
And
I don't know.
it's a great question. It's so dynamic, right? Dependent upon, this isn't like somebody who has to have Levine sign. That's that massive crushing chest pain.
They don't.
They might, right? But just because it's an absence of, there's no clinical correlation. This patient may be compensating very well. They may be just having very light chest pressure. It may be crushing chest pressure. You may look at them and go, oh God, this patient's sick, versus, nah, they're doing okay because they're compensating right up until the point they ain't. And then you go, oh God. That's what this EKG says to me is, great, I'm glad my patient's compensating if they are, but I'm going to be very cautious. I'm going to be very ready. I'm going to have 3 different therapies set up for when they do crash. And if I don't have to use a pressor at the end, great, I'll throw it back in the box, but I'm going to lay out. I'm going to be more anticipatory in my clinical management of this patient.
Hey, Steve,
Makes
you have
sense?
a question in the chat about Justin said that his training is that depression in the precordial leads indicates posterior involvement.
Well, hold on to that thought just for a minute. I like that because it does if it's isolated, right? The difference in a isolated posterior wall MI that we'll be talking about and this AVR ST elevation is that AVR ST elevation in combination with precordial ST depression and a widespread ST depression in the precordials, as opposed to a localized that we'll see in a posterior involvement. And we'll talk about posterior wall MIs here in a little bit. That's a great question. So did that help out, Justin? What do you think about that? Is this patient compensating? Maybe, not for very long, right? AVR ST elevation, we've got, let me see if I can zoom in on this. Let me see if I can go down just. So we have AVR ST elevation of about 1, 2, 3, 4 millimeters. Oh, look, V1's ST elevated, V2's ST elevated. You see how this is progressing along, how this is evolving. All of the other leads are even the reciprocal leads, right? This is a massive left main coronary artery lesion. And if they are compensating, it's probably not going to be very long. So here's my question then. This is AVR elevation. Does this EKG meet STEMI criteria?
I believe that it does.
Anybody else? I can zoom in.
I vote it
Absolutely.
does.
Is there ST elevation in 2 or more contiguous leads? Shake your head up and down. That's a
Yeah.
check mark in the box. Is there reciprocation? ST depression in 2 or more contiguous reciprocal leads. Shake your head up and down.
Yes, there is.
So at some point in time, we're going to get to meeting ST elevation criteria with this.
This is
Right?
already
It's
bad.
the subtle stuff that we're missing because this is the evolution of it, right? We want to catch it when it's more subtle and get that patient to PCI capable facility.
Yeah.
Right. Hopefully, yeah, I mean, if this is happening in front of your eyes, it's what's that other clinical abbreviation we look for? PUHA. PUHA. Pick up haul ass. It comes right before FUBAR.
But after the sphincter.
Yeah, in the whole sphincter thing. Yeah, absolutely. All right. So any questions on AVR ST segment elevation, and we'll move on to left bundle branch. Okay. So the left bundle branch block. How many of you have taken a patient in that had a left bundle branch block on EKG, handed the EKG to the receiving physician / provider / and they go, oh, that's a left bundle, and throw it on the counter? Because we can't tell anything in a left bundle or ventricular paced rhythm based upon a 12 lead. Well, kind of, sort of, maybe. Okay. There's this whole thing called the Scarboza criteria. Even further specific is the Smith modified Scarboza criteria. And yes, you can, with a fair amount of sensitivity, be able to determine whether somebody meets ST elevation MI criteria in a left bundle branch block or ventricular paced rhythm. Okay. So even, V paced versus left bundle, it's the same characteristics. You can have a widened QRS greater than or equal to 0.12 seconds. It may be, your QRS duration may be a week and a half long. I think the highest QRS duration I've ever seen was 0.26 seconds. So if we think about that, that's the time and the velocity of the conduction moving through the ventricular pathways, right? So it needs to be less than 0.12 seconds, fairly quick. And as that widens out, can we extrapolate that time to cardiac output? Absolutely. So if it's the wider it is, what can we say about left ventricular function?
It's going lower.
It's going lower and
Lower and
lower. It's
lower.
getting softer and softer. That force of contraction is getting
You get to
softer
the
and
bottom of the
softer.
barrel, so to speak.
Absolutely. And if we think about all of the waveforms, this isn't a full 12 lead class, right? But we measure velocity, amplitude, and we measure time, right? So we want our atrium to contract from the top down in a nice squeeze. And then our ventricles to take over and squeeze from the bottom up. And that's called syncytium. As soon as that, and when that syncytium is delayed, we have a drop in cardiac output that may or may not be clinically significant, but I can look at that EKG and go, yeah, this patient's really got some compensability. versus, oh God, right? You got a QRS duration of 0.24 seconds. It's taken half a day for that ventricle to contract, right? Your cardiac output, your inotropy is down. And they're going to compensate for a little bit, and they're going to crash right in front of your eyes if they do. Okay. So dominant S wave in V1, the old turn signal theory, right? If you're driving your car and to determine right versus left bundle branch block, and you turn on your left turn signal, you push it down, that's left. If you push it up, that's right. That's kind of the same analogy as V1. If it's downward deflected, it's a left bundle branch block. If it's upward deflected, it's a right bundle branch block. We'll get into the meat and potatoes of that here in a little bit. Okay. So what is Smith modified Scarboza criteria? This comes from the audience. Help me out here. Oh, well, stand by.
Mhm.
I want to get a good graphic representation of this. So let me see if I can do this without totally screwing stuff up. So I think my computer is in having a left bundle branch block. Um, so it takes a long time to get through.
It's because it's a million.
It is a million years old, kind of like me.
It's a curmudgeon.
So let's talk about Smith modified Scarboza criteria. This is a waveform detection that we can utilize in both left bundle branch block and ventricular paced rhythms. Okay, so there are one of three ways or three of three ways that you meet criteria. If you meet criteria, it then is a STEMI equivalent. Does that make sense? Okay, and in some systems, it is an alert. That would be a system-wide thing.
We're talking about two different criteria, though, right?
So I'll describe what's different between Scarboza and the Smith modification. The only thing that the Smith modification did was increase sensitivity, because in the only thing that it changed from Scarboza was that number 3 point. And the Scarboza criteria used to say in the precordial leads, most specifically V1 and V2, if you had ST elevation of greater than 5 millimeters, it met Scarboza criteria. Well, Dr. Smith came in and did this huge randomized trial, and because if you look at your QRS volume here, your amplitude, right, the deeper that amplitude goes, the more reciprocal that ST elevation will be. So he came in and he said, 5 millimeters is good, but let's hone this down just a little bit more. And if that is greater than 25%, the total R wave height. Okay, so, or S wave, sorry. Okay, so here's our S wave. Can everybody see my little finger here? Okay, here's the S wave. So we want our ST elevation to be greater than 25% of that. So your initial measurement is your S wave. And this one looks to be 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17. 17. Whew. Took me a while to get there, huh? Now we got to do some math at 3 o'clock in the morning.
Mm.
Okay. Okay, so this is really cool because I'm kind of a visual person. I look at that and go, is that greater than a quarter of the height? No. Okay. Greater than a quarter. Make it simple. Okay. So that then is the Smith modification. Realistically, is the Scarboza criteria good enough, highly sensitive enough for EMS?
No.
It's not a trick question.
My little,
Yeah, he's got the head bobble.
My analytical brain says, oh, hell no, that's not accurate enough. I'm bouncing down the road at 60 mile an hour, headed to the ER, looking at an EKG through my bifocals. I've taken my Aricept, put on my Depends to go to the call. Scarboza is good enough. Okay, greater than 5 millimeters. Keep it simple. Andra, do you have argument with that?
No, I don't. And I put in a link in the chat about a good journal article that kind of describes the difference between the two because John had asked about the term. But no, I agree with you.
Okay. I'm glad when we agree. Questions about the Scarboza criteria. So we're looking for number one, we're looking for concordant ST elevation of greater than 1 millimeter. So what is concordant? It's in the same direction as the terminal velocity of the QRS, right? We're looking for discordant ST depression, more specifically in V1 through V3, the right and mid precordial leads. Okay, so that's step one. Step two, you can have one or the other. They can be conglomerated. And then step three is greater than 5 millimeters of ST elevation in the precordial leads. All right. Let's move on here. Questions about this before we move on? The winners. What is the DeWinter's T-wave? Well, this is a classic example. We talk about injury and infarct. We talk about our T-wave, our ST segments over time, how they develop, what they look like. I look at DeWinter's as being a massive hyperacute T-wave in the injury stage, right? So broad, tall, non-peaked. Some people would look at this in V2, V3, V4, even V1 and go, well, those are massive T waves. I think it's hyperkalemia, right? Because they are tall. They're incredibly tall. They look like a hyperkalemic T wave, except they're missing one thing. And that's the tent, right? So if we look at this at the top of the T wave, it is more broad. At the bottom of the T wave, the base of the T wave is more broad. A hyperkalemic T wave meets the criteria of the base being narrow, which is what makes it tented at the top. Okay, so this is a broadened T wave at the base, at the isoelectric line. If we look at this, let me see if I can zoom in even more without really screwing something
Is there
up.
a box standard for that though? Or no?
There is not.
Okay.
that's not like,
You can't just count it out.
Yeah, you can't just count it out.
Okay.
What is the normal duration of a T wave?
Steve, you make me get that.
Oh, that does mean something now, doesn't
Yeah,
it?
it does now, 0.
Damn it, it got us through the test at one point in time, but it didn't mean anything in the field
Is
right up until now.
3 small boxes of 0.12? Or
0.16 to 0.20,
0.20, okay.
okay?
So I was in the middle.
You were in the middle, right?
Still count.
So let's look at the base of this T wave. How many small boxes is this?
Oh, good God.
It starts right here.
More than that.
It looks like
It's more than
Nah.
0.12. I don't care if it's
It doesn't matter if you count as.
2.26,
Oh,
right?
it's seven.
Yeah.
It's broad.
You-
It's tall. Okay.
Okay.
I do have an example
Leave it together.
of a DeWinters and a hyperkalemia here in a little bit. Make sense?
Yeah.
Okay. Typically, there's an upsloping ST segment and depressed. We saw that right here in V2. See the upslope, and actually your J point is
Yeah.
depressed. Okay. If we look at V3, let me see.
That's actually a strain. Is that a strain pattern?
No,
No.
it is not.
Okay.
If we look at V3, we're absolutely depressed.
Got it.
Okay. That's not V4. V4 is over here. V6, absolutely.
Yep.
V5, absolutely.
Yep.
This is a whole lot different moving this than just zooming in. Okay. So what is DeWinters? What is it significant of? If we go down to characteristic number 5, ST elevation of about 0.15 to 1 millimeter. We just talked about ST elevation in AVR. What was it significant of? Left main coronary artery occlusion. What is DeWinters significant of? Another pattern of left main disease. Okay. So kind of a problematic situation there. Out of hospital ROSC. So by protocol, realistically, once we get ROSC, and we have a hard time walking when our ass is out in front of our feet, and our ass is out in front of our feet on every cardiac arrest that we get ROSC on, because we're all high five and low five and hell yeah, we got this.
10 minutes later.
And 10 minutes later, you're like, damn, I wish I would have got a 12 lead of that. Yeah, that'd be cool. and then, well, or 6 hours later, when Andra's in town doing training, and she goes, hey, what was the post-ROSC 12 lead of this guy? We're like, well, we don't, we didn't get a picture of it from the ER because we didn't do one. Okay. That is significant. We really should pay attention to that. And now granted, we are task saturated, depending upon your crew resources, depending upon, but really think about getting that post-ROSC 12 lead, because it may be, and even more importantly, once you have those electrodes on the chest and on the limbs, don't move them, right? Hit that 12 lead button 2 or 3 times, because we want to be able to measure the evolution or the improvement in cardiac conduction pathways. Okay. We want to be able to say with some specificity of whether this cardiac arrest was caused by a coronary artery occlusion, and do they need acute PCI? I'm in the super rural environment. Guys, I am 2.5 hours away from Denver. I'm 2.5 hours away from PCI. And sometimes in Colorado, things can't fly, right? I want to know whether this patient's going to have to go out to get PCI, or whether we got a few minutes. Okay, that's the biggest thing. Why did I put so many 12 leads on this slide for you to look at? Because it can be one of each one of any one of every one of at any time, any one of these EKGs. Get the data. Okay. Subtle inferior wall MI. So let's look at this 12 lead. And since I've got my zoomer inner kind of working, and I'll screw this all up. Let's look at this 12 lead EKG. First of all, what's the rhythm? You don't see a P wave. You don't see a P wave?
No.
I wish it would be about 6 beats faster so we could see the next complex to
Yeah,
see if
'cause-
it had a P wave.
It probably won't soon.
I do see a P wave in lead 2. I see a P wave in lead 1. I do see that the PR interval is maybe a little short without the presence of a delta wave. So that's not WPW. Okay. What else do we see in here? Do we see any ST elevation? Yes or no? I see elevation in 3, elevation in AVF. To meet STEMI criteria, that needs to be, depending upon who you read, who you think, and what your protocol is, used to be 2 millimeters. Now most protocols are 1 millimeter throughout, right? Even if we say it needs to be greater than 1 millimeter of ST elevation, I think we're sitting right at 1 millimeter. Does this meet STEMI criteria? Not for elevation. Is there reciprocation? There is, just not enough. So it doesn't meet STEMI criteria. Is this person having a STEMI? Shake your head up and down. It goes this way. Absolutely, they are. One of the most important things in this is to recognize the changes and anticipate evolution, right? We're catching these ST changes in the inception of what's going on.
So it's the
It's
preview.
likely the preview of what's to happen. So anticipate that. This is enough for me to look at and go, you know what? This is an inferior wall injury. And so I need to start thinking about inferior wall. Maybe I'm going to go ahead even on this and get that V4R lead to see if it matches. Probably still won't meet elevation criteria, right? But I want to take a look at that lead. But the biggest thing I'm going to do is I'm going to keep my electrodes on. I'm going to probably poo-ha. Remember what that is, right? Make the wheels on the bus go round and round, round and round, right? Okay. I'm going to move with this patient, but I'm going to keep the leads attached and I'm going to do serial EKGs. Okay. I'm going to catch this because it's happening. Okay. Not enough to call on the radio and say, hey, we're coming in with a cardiac alert. Fire up the cath lab if you have one.
That's still
Right.
split.
But wait for it
Yep.
because it's going to happen. And then you got a 15-minute transport. It's probably going to happen probably that quickly. Now, we may see some changes with our treatment, right? We give aspirin. We don't see a change with aspirin. Here's a question. I want it voted in chat. Do you give this individual nitroglycerin?
We get some-
No, all you get is sublingual
I would.
chicken.
What are the current titles?
I don't care.
I do.
Why?
Because I don't want them to be hypotensive.
Oh, so if they're hypotensive, you won't give them nitro,
No,
but what if they're hypertensive? What if they're normotensive?
That's a good
if
point.
they're like 60/0.
I mean, that's a diagnostic, 60 over
Sure.
0. You know what to do with that.
Yeah.
You have to think
Everything.
ahead of where it's evolving to.
You what?
You have to think a little bit about where it's going, where it's
Yeah.
evolving to before you do this. I wouldn't.
Wouldn't?
I might try it, but I want to know some more information.
Okay, so Travis wants to know some information. So I'm gonna give him some information. Blood pressure is 120 over 80.
Oh, shit.
Are you gonna give him nitro? Is nitro contraindicated? It's a special consideration. Absolutely. Consider what's going on. If the patient's hypertensive, I wouldn't be scared a bit. If they're normotensive, I probably wouldn't be scared as long as I had IV access and the ability to give a fluid bolus,
Yes.
right? And if they haven't taken any phosphodiesterase inhibitors and all of the indications and contraindications, we've got ourselves wrapped around the axle of not providing nitrates to anybody who has inferior wall changes. And
One thing from school.
that's what's being taught in school. And that is incorrect. Think about what you're doing, right? Would I give it if they're soft pressure? If they had a pressure of 108/50, probably not, especially without a fluid bolus. But normotensive or hypertensive, I wouldn't think twice about giving nitro. Do they need the benefits of nitro? Meh, depends. You know, we now have some studies that say nitro really doesn't provide really any outcome benefit, right?
More.
Andra, weigh in on that, would you?
Yes, so my general practice until science proves us otherwise is that nitro does not have any outcome benefits. And so it is a good tool for symptomatic management, but it is not life-saving, heart-saving, muscle-saving in any way. So that's my 2 cents on the nitro specifically.
So
There's-
this combined with chest pain.
Say that again.
I said, so this EKG combined with chest pain, symptomatic.
Yeah.
Right.
I mean, there's some data that's starting to come out that what we're classically taught about right-sided is maybe not true about not giving nitro, but I don't think we're there yet either, to change practice patterns quite yet.
Love it.
Steve, can you hear me?
Go ahead.
Okay, this is Joe Negabar. I had an interesting case in Sedgwick County that I had a female who was having chest pain all day long. She rated out a 5 out of 10, called us that night to her house. I did a 12 lead, was unremarkable. Blood pressure was 140s over 80s. Did an IV, put her in the back of the ambulance, and gave her a nitro, turned around to check a blood glucose, and she went into VFib. So I shocked her, started CPR, and then she woke up and started talking to me 2 minutes later.
That qualifies as a save.
I just thought that was pretty, I guess, a kind of a different call that I've never seen happen before. But do you think the nitro maybe caused her to go into that, or do you think it was just the chest pain portion of it?
I don't know that we could say, right? I mean, you would think that it wouldn't be direct relationship to the interruption in cardiac conduction, but without saying she tanked her blood pressure because she had an RVMI, because it's a preload dependent situation. She didn't have enough preload. She deoxygenated. I mean, there's so many what ifs to that. I don't think we could scientifically say, and I don't think we can anecdotally estimate, right? Could it be? I don't know. What do you think, Andra?
I haven't heard of this happening, but I was trying to frantically kind of do a little lit search to see if there's any evidence for that. Although I did get a text from another one of my wonderful medics who said she had the exact same thing happen too, and the hospital told her that sometimes it happens. So I will do some literature.
That's interesting.
Yeah.
Added information to that is they did, the lab work and all that kind of stuff. And she did not have an elevated troponin or nothing, but they did fly her out, and she did have 2 blocks. So.
Oh, wow. Well, that's an interesting rabbit hole to go down. I like it. It's the biggest thing with subtle lateral MIs. Lateral MIs in their presentation, in their EKG presentation, are really, to me, anticlimactic, right? I mean, you look at this EKG and you're like, meh, doesn't look that bad, what is the physical problem with lateral MIs, more specifically a high lateral MI? What's the potential problem that really scares the hell out of me? Well, if we think about where that occlusion is, like I said, more specifically, a high lateral, or that isolated lead one and AVL elevation, which is probably fairly subtle. Think about where that's occurring. That's right at the left outside upper wall, right at the atrium ventricular sulcus. That there's that, what do they call that valve thingy right there? That mitral valve, that now all of a sudden you have no oxygen to the papillary muscles. And so you get papillary muscle dysfunction and a floppy valve. Or here's the one that scares the real hell out of me. Now all of a sudden that papillary muscle decides, you know what? I'm out of here.
Yeah.
I'm done. I'm going to go ahead and rupture. Now you got a free flow of atrioventricular flow. Yeah,
You're in trouble. big
yeah,
trouble.
AMF yo-yo, right? Without balloon pump and cardiovascular surgery and so give this one some respect just because of where it is. It's not that big, huge MI, but man, if things go south with this one, it's problematic. One of the bigger things, I'm gonna hammer on this and beat on this, especially in these situations, is serial EKGs. I want to detect subtleties in evolution, right? This EKG does not meet STEMI criteria. That's why it is on a STEMI equivalent, okay? We look at the upper EKG here. We see that there's some depression. There's some reciprocation in the inferior leads, lead 3, lead AVF, and quite possibly 2. We look at lead 1. Let me zoom in just a little bit here. Now I got to figure out how to move that down. We look at lead 1. I mean, it kind of looks like there's some elevation, but it certainly doesn't meet STEMI criteria. We look at AVL. AVL, it's elevated, right? But doesn't meet the classic 2 millimeters for STEMI inclusion. But you look at this EKG as a whole, and you're like, you know, I don't like that. This should get your spidey senses up. Okay? This should get your spidey senses up. This is going to evolve. This may be very problematic. I have had one in flight that actually had a papillary muscle rupture. And it was a bad thing. They did make it. We were about 5 minutes out in flight going to Rapid City, South Dakota, when they ruptured, and it was quite evident that it ruptured. Our blood pressure went from hypertensive to 40/0, like that. But you got a floppy mitral valve. Shit just ain't working no more, right? And so we were able to support pressures, called ahead and said, I said to Rapid, I said, I think we have a papillary muscle rupture secondary to a high lateral wall MI, and they went right to the OR and put them on bypass, got in, did mitral valve replacement with the cath lab, placed a stent, and they did kind of okay. Had that happened 2 minutes sooner,
No.
they'd have been dead. Okay. Questions about subtle laterals? Okay, so here is an example of that hyperacute or that Wayland's T wave, right? It's huge, it's tall, it's probably as tall or taller than the QRS in the hyperacute or Wayland's phase. It's broad, it's wide, it's typically associated, Wayland's is associated with a little nondescript ST depression. It can be elevation as well. Okay, versus hyperkalemia is a narrow-based hyperacute T wave, and it's tinted. See the difference in, and not necessarily the amplitude, but the peak of it, where the hyperacute and or Wayland's is more broad than a hyperkalemia.
Or the winters?
DeWinter, sorry. Yeah, go God. Yeah, sorry.
Gotcha.
Sorry. Yes.
Okay.
Not Wayland's. Wayland's is totally different, right? You got type 1, type 2, or type A, type B. Oh, man. So,
It's just, don't harp on it.
yeah. So, give me just 2 seconds to think about this, because in presentation mode, there are evolutions of EKGs in this. Let me see if,
EKG one, is that the one you're trying to do?
what's that?
EKG one.
Well, yeah, I can click on EKG. No, because of group. Stand by. Let me see if I can make this work. Works really well in presentation mode.
If you right click on that one again and hit that bring to
Bring
front,
to front.
it'll pop it.
So here's the first EKG. Really kind of nondescript, isn't it? Now let me move this one out of the way and go to ungroup those. My God. This is challenging the senior citizen. Oops, see the difference? Listen again. I kind of moved off, you can still see it. See the difference in the precordial T waves? So that's an excellent example of a hyperacute T wave. We see in EKG number 1 in V2 and V3 that they're starting to evolve. It's very nondescript. We go to EKG number 2, and we see that they're becoming hyperacute. This one out of the way and do this one. See the difference? So now we have one over here, not much. I mean, I look at that EKG and I go, yeah, okay. It's a sinus rhythm. It's got low voltage amplitude. Maybe they got COPD. Likely they have COPD, right? And because I'm a good paramedic and I listen to the fat old man that has Depends and Aricept talking on Zoom and kept my electrodes on and did perform serial EKGs, and I got number 2, and I went, oh, that's kind of a change. Notice one thing here that we don't see much for reciprocation yet, though, right? This is the evolving. And then number 3, they become huge. We start seeing the ST segment elevation in V2 and V3, and this is going to continue to evolve until such a time that they get to the cath lab. Isolated posterior wall MI. I believe it was Justin that had the questions with this, right?
Yes, sir.
So isolated posterior wall MIs are really one of the most missed MIs, because much like the subtle lateral wall MI, they're really kind of anticlimactic. You see a little bit of ST depression in V1, V2, possibly V3. We used to call that the window theory because we don't have posterior leads. We're seeing reciprocation. Okay. So if we think about our ST segments in either elevation or depression, they need to be flat and elevated or flat and depressed. Okay, so we call this carousel or saddle depression. And that's why I drew the cute little pony in V2, because that's saddle depression. It looks like you can sit in it and ride it, right? It looks like a carousel horse. There's no other ST elevation. It doesn't meet STEMI criteria. So therefore it's not a STEMI. Yeah. I drew that with a mouse even.
That's impressive.
I erased it about 17 times, but I finally got there. So yeah, it doesn't meet STEMI criteria. Is it an occlusive myocardial infarction? Shake your head up and down. Absolutely. Now, if we think about this from a myocardial real estate standpoint, what part of the heart is affected by this? If it's an isolated posterior wall,
So it'd be the back side of your right ventricle.
backside of both, right?
Those are your
Ah, they're your septal leads only on the backside of the heart. Oh God. That's no bueno. But we look at the EKG and it's like, meh. It's a big deal. Now that's an isolated posterior. It can be associated with an inferior, most likely, because it's a right coronary artery that comes around and perfuses the posterior side of the heart in 75% of the hearts. There's always physiologic anomalies, right? Aha, posterior EKG, V7, 8, and 9 is going to be confirmatory in that.
So they taught me during paramedic school, and I don't know that it's right, but something that I was taught was the way that your layout is of your normal EKG
Mhm.
and translate in the mirror all B leads to the posterior side. Is that true? I've never done it, but
Essentially,
I mean,
That's a
your lip
15
leads are
lead.
still the same.
so 18,
Well,
like
just
the new
moving-
Life Pack 35 that you
Yeah.
can do, 18, it's all right-sided, all left-sided, and posterior.
They taught us like take your V leads, move those to the posterior mirrored where you would have them on the anterior side. I've never actually done it though.
And it's not necessarily necessary to move all 6,
Just the-
move 3 of them.
Yeah.
Right. Yeah, yeah.
But you have to, and also label your,
And also label your leads. Yes, please. That's a good thing.
you're not like, what is
Yeah,
this?
exactly. Doc looks at it and you're going, how the hell did this happen? Right?
And you're a paramedic?
Yeah. Well, no, not really, but I stayed in a Holiday Inn Express last night. So makes sense? We'll get some cases here in a little bit. And we'll see that an example of posterior inferior posterior.
I had a question.
Yes.
So with V1 and V2, you have that depression, not for V3. How do you tell if it's anterior or posterior? Because I'm guessing V1 and 2, that's atria, right?
It's septal leads.
So he's saying posterior because it's depression, anterior would be
Elevation.
elevation.
Right. Yeah, okay, got you. Misunderlistened.
I
Sorry.
don't know much about this.
No, you're
Then
good.
what we're saying
No,
is
it's a
if you
good
move
question.
those leads to the posterior side, you should see
Yeah,
elevation.
elevation.
You're just changing the camera angle. That's
Yeah.
all.
Because your positive lead is your electrode, your negative is your V leads.
Do you move those leads to the back?
Uh-huh.
Yep,
Yep.
We had-
We used to do that before we got all of them.
yep, exactly.
You only had a couple of cords in order to get a whole Make sure you have to keep moving them.
Quick
and then
six.
Paste them together and.
In 1942.
Oh, no, back in the day, Life Pack 9s, before they came out with this heavy duty IT 12 leads and transport cardiac monitors, the Life Pack 9, you used to be able to do modified chest leads. So it's a 3 lead,
Uh-huh.
and you take your left lower lead and put them on the precordial leads and turn it to lead 3. That gave you a modified chest lead, MCL 1, 2, 3, 4, 5, and 6. Yeah, it was
Nothing
kind
could
of
go
cool.
wrong at night doing that.
No, never, never, absolutely. Okay, so here's an example of isolated posterior wall MI. You look at this EKG, you're like, meh, doesn't look all that bad, right? I mean, there's some ST depression in V1 through V3, arguably V4, but does it look like saddle depression or carousel depression? Could you sit in that V2 and look like you're riding the carousel? And for you younger guys, that was a merry-go-round a long, long time ago.
What's that?
Yeah. It depends. Absolutely.
Yeah.
So you move then to your 7, 8, and 9, and that depression becomes elevation. That's confirmatory. Okay, let's take a 10-minute break. We'll come back and talk about STEMI mimics, and then we'll get into some cases.
And during the break, sorry, Steve, to cut you off, our rural EMS education series grant folks would like us to have you guys fill out a survey. It's really short. It's like 4 questions. I'm putting it as a link in the chat, and then I will steal the screen just to have it up as a QR code for the break, if that's okay with you, Steve.
Absolutely, do your thing. So we've talked about
So if you wanted to-
all of the STEMI equivalents, right? That's the stuff that we don't get, we don't gather, we don't alert because it doesn't meet that special criteria, right? I hope that I illustrated that they're bad things, right? Every one of them are bad things. So now we're going to talk about STEMI mimics. Things that look like STEMIs, that may meet criteria for STEMIs, but are not.
Hey, Steve,
Yeah,
you need to share your screen again since I kicked you off.
yeah, I can probably do that if I can figure out how. Share that one. That one. Is that more better?
Much more better.
Cool. All right. So STEMI mimics or ST segment elevation caused by different underlying pathology. Wow. Crap. Right? How do you know? Chicken or egg? Does it matter? Well, as we'll see in some of these are even bigger oh my gods, right? So we're alerting because they meet STEMI criteria, but they're not STEMIs. They are stuff that's as bad, if not badder. Again, there's a mnemonic, right? STEMI mimics, raised ST segment. I don't know who thought these up, but they were good, right? Raised intracranial pressure, aberrant conduction, again, left bundle branch block, and left bundles just really screw things up. Inflammation, being pericarditis, spontaneous coronary artery dissection. Well, that don't sound very good, right? Electrolytes, the big one, hyper-K, hypocal, right? A device, ventricular paced rhythms. Well, we already talked about V-paced and left bundles, right? Sodium channelopathy, that's that Brugada syndrome that you probably heard about. Thoracic aortic dissection, well, that's a bad stuff. And spasm of the coronary artery, so it's called SCAT or Prinz metals. Embolism, being pulmonary, grief, that's that broken heart syndrome, that Takotsuba's cardiomyopathy, myocardial infarction recently, that's now becoming a ventricular aneurysm. That's a bad thing. Enlarged ventricle being LVH, maybe normal, which is benign early repolarization. That's what we miss a lot in the field, is to go, oh God, they got ST elevation, but they don't have depression. We forgot about that whole reciprocation thing. And it's just a benign situation of early repol. And then of course, hypothermia. Okay. So raised intracranial pressure. See if I can get my fingers working again. And everybody see that EKG a little bit better. Okay, raised intracranial pressure. So this is typically in spontaneous hemorrhages. We'll see what's called cerebral T waves, right? And they can be very profound. This one really isn't all that bad. It almost looks like what other syndrome that we talked about, or what other path that we talked about.
Wellens kind of.
Yeah, it does. It does. The differential between a cerebral T wave and a Wayland's T wave, or type B Wayland's, is that the cerebral T waves are much more broad. If we look at, let's take just V2, and we look at that T wave, we can see that it is way broad. It actually gives us a prolonged QT, right? Our QT interval is greater than 50%, which is the 3 a.m. rule, not the whole calculated. It's 3 a.m. You just peed on a dumpster. It's Miller time. You're looking at this thing and it's greater than 50%. That's prolonged QT. They're really deep. They're really inverted. And that is in relationship to typically to intracranial pressure.
Are all the T waves going to be inverted, or will you see mixtures?
You can see mixtures. Usually it's throughout the precordial phases. Okay. We call this a STEMI mimic because that whole reciprocation thing. We look at this T wave inversion as being reciprocation, and it's not reciprocal to anything. We don't have any ST segment elevation on this, so it doesn't really truly fit our criteria. Aberrant conduction, left bundle branch block, just like we had talked already. We use the Scarboza criteria, and that then places it into or out of STEMI criteria. Okay. I'm going to blast through some of these. This is a really good, let me see if I can, you guys want to take a picture of that? You certainly can. This is the Scarboza criteria. This is the Smith elevation, but still we've got, or Smith modification. We still have that 5 millimeters of magic ST elevation. Pericarditis. Gotta love me some pericarditis. What's pericarditis? Do we have indication or ST elevation? Yeah, where?
2, 3, 6, anterior, inferior,
Lateral. You might as well just say all of them. Yeah, all of them. Yep. Widespread, would you say? Absolutely. Look at that ST elevation. Is it concave or convex? It is convex, isn't it? What do we think about this patient historically? What does their chest pain feel like? It's typically sharp and stabbing, right? As opposed to the magic pressure. And what typically alleviates it?
leaning forward.
Leaning forward. Absolutely. To get that pressure off that pericardium.
Yeah.
Right? Okay, so those are kind of some of the differentials. Truly, what is the diagnostic factor for saying this is pericarditis?
History of infection, probably.
Might, that's an inclusion criteria, right?
Gotcha. Labs.
Labs and things that we can't do in the field, right? I don't feel really poorly about alerting this at some point in time because it's still a sick heart. We may have an effusion, a pericardial effusion that goes along with this, clinically or subclinically, right? It may or may not be affecting our heart. It may or may not be tamponading the heart in some form or fashion. Typically, if it is, you'll see some electrical alternans. Do y'all remember what that is? That's that change in amplitude of the QRS on the EKG. And we don't really see a lot of that here, right? I mean, if you draw a line straight across, there may be, see how this one's smaller than this one's up? You can get a beat to beat variable, right? And that literally is that fluid, that effusion in that pericardium that is being sloshed around, if you will. Okay. But its lack of or presence of doesn't mean a whole lot in the end, right? We need a lot of labs. We need a lot more diagnostics. We need an ultrasound. We need a cardiologist, and we may need a cath lab. Okay. SCAD. Oof.
What's this one?
Sudden coronary artery dissection. And it can really run the gambit. Typically a tearing sensation. It's a profound chest pain, typically. Again, we also have to think about the creation of a pericardial effusion and a tamponade situation. Okay. This can certainly be life-threatening, right? If we got a dissection in the coronary artery, whether it's leaking or not, right? We've definitely got a reduced blood flow distal to that dissection. And so depending upon where that dissection is, the reduced blood flow causes EKG changes. Oh, it's going to get noisy here for just a second. Hang on. Okay, kids are going to bed. That's my alarm. Okay. So we may be able to localize that as, let me see here. In this EKG here on the lower left, we do see some ST segment elevation. We actually see some reciprocation. This one almost meets STEMI criteria, but it doesn't because it's less than 2 millimeters and it's not in contiguous leads. But nevertheless, I would say that this individual has had a coronary artery dissection somewhere in the mid LAD because we're seeing anterior changes. Does that make sense? Doesn't meet STEMI criteria, still a bad thing. Right? Again, what's lacking in this is reciprocation. Make sense? You can see here in my notes, spontaneous coronary artery dissection is first described in 1931. Healthy 42-year-old female tips over dead after vomiting. Oops. It may or may not be associated with some sort of physical trauma. Oh, here we go. Hyperkalemia. Too much potassium done floating around in there. This is a pretty profound hyperkalemia. What do you see in this EKG?
Super wide.
Yeah, QRS is super wide. It's trying to come onto a sine wave. I see loss of P wave.
Yeah. So
what would you say that their potassium level is looking at this EKG? Is it greater than 7.5? Remember that whole thing in paramedic school of hyperacute T wave is greater than 7.2776?
I remember it, but I don't remember.
Okay, remember this. there is zero correlation to level of potassium in the blood. There are too many other factors. Are they end-stage renal disease? Is this a primary onset? Is it secondary onset? There's too many factors. Here's what we do know, is that there's too much potassium in the serum. And that potassium to sodium gradient has changed the conduction pathways. And we need to park that potassium because nothing we do gets rid of potassium. Do you need to treat this patient for hyperkalemia?
Yeah,
Absolutely. And so what do we do?
calcium.
Now, calcium, what's calcium do for hyperkalemia?
Drives the serum potassium back into the cell.
Nothing. It stabilizes the cardiac membrane and the action potential. That's it. It reduces that gradient. Okay.
Yeah.
So it's cardioprotective, quote unquote. Albuterol. Why do we give albuterol? Very little on the sodium potassium pump. It actually physically moves serum out of potassium out of the serum back into the cell. But there's a caveat to that. It requires more than one 2.5 milligram bullet. Typically, what I've read is greater than 10 milligrams. Perfect. I mean, if you got high concentration albuterol, it works. Other than that, at your fourth treatment, you might see some move. Okay. What's the next thing?
Sodium bicarbonate.
For what?
I was gonna say just a serum drive the potassium out of the serum into the cell again.
It assists in it. There's some thought that because of the reflex acidosis that can be caused by it, that in the end, it can be harmful. The two mainstays of treatment for hyperkalemia are what? Calcium and albuterol, continuous, flats. Okay. You will see a dramatic change in the QRS duration, typically after calcium. The one caveat to that is if you give calcium, more specifically for hyperkalemia, how long does that last? You may buy 20 to 30 minutes. So, and I only say that to say, if you give calcium for the treatment of hyperkalemia, be ready to give more. Okay. It may be a call-in. It may not be standing order, but that certainly is, you do have the ability to, yeah.
On like, leads to 3A, is that a P wave or is that like a RSR?
Ah, that's good. So remember, as our potassium comes up, we lose a P wave.
Yeah.
Right? So this is actually truly an accelerated junctional rhythm. So that's a very good question. That's actually a what? It's an R wave. Absolutely. So how wide is our QRS duration here?
Very wide.
About a week and a half.
Yeah.
Yeah. Okay. And that's what it's doing. That QRS is pulling out and going to become a sine wave. Okay. So ventricular paced rhythms. So I've been doing this a long time, and I got to tell a story about me.
Is it dog ears?
Well, I know not dog ears. I hate dog ears and rabbit ears and every kind of ear. They ain't no ears. I have never seen an ear on a damn EKG. No. Okay. So we get called to right across the street from our EMS base for a man who's wrecked on a mini bike. And we get over there, it's literally right across the alley. I ran out the back door, ran over, and Grandpa's kind of down. He hit his head, bought himself a ride to the hospital, put him on a monitor, and I'm like, oh crap, this guy's in VTAC. Well, that would be a cause for a fall, wouldn't it? And so we're running him in. He's got like, I don't know, 22 millimeters of ST elevation in the precordial leads. And you literally in the back of the EMS, my rectal sphincter slammed shut. I'm like, oh, this isn't good. Right?
I feel like it does that a lot.
Yeah, it does. It kind of does.
Lots of practice.
It's practice, yeah. So as we're pulling into the emergency room, after I've called a cardiac alert, after we ran him in emergent, we damn near IO'd Grandpa. I decided a good paramedic would hit print and print that 12 lead. And it's on a life pack. I love life pack, kind of, sort of, sometimes. What I hate about life packs is you don't see pacer spikes. But on a 12 lead, you do see them magic arrows.
Mm-hmm.
And so I'm printed it out, and that's when you heard that's when the rectal sphincter opened up. Because I'm like, oh shit. We just ran a paced rhythm in, hot, got everybody in for no reason. Okay.
It's gonna be a day.
Oh. Okay, they're going out. So pay attention. Keep your ass behind your feet. It's easier to walk. We don't recover very easily from those honest old man mistakes. Okay. So Grandpa tipped over, hit his head. He probably needed to go to the ER. Didn't need to go lights and sirens. Didn't need to do a cardiac alert because he was in a ventricular paced rhythm. Okay. Same rule applies on V-paced rhythms as does left bundle. The Scarboza criteria applies in these situations as well. Sodium channelopathies. So Brugada syndrome. Brugada is hereditary. Thought to be sudden cardiac arrest in structurally normal hearts, right? So it's thought to be the cause of arrest. You know, we hear of these cases of adolescents that not a situation of commotio cordis, right, where they get hit in the chest, but they're running down the basketball court, they're playing basketball, they're exerting themselves, and they tip over and they have a cardiac arrest. That is typically thought to be one of the causes is Brugada syndrome. And so much like the others, there's different types of them. So remember Wayland's, we had a type 1 and a type 2. Brugada, we have a type 1 and a type 2. In type 1, we have an extreme elevation in the J wave, right? So we see here that we have the QRS complex comes up, makes a J wave, it's elevated, okay? So, and that needs to be greater than 2 millimeters. Well, obviously this is. We have a negative T wave, and there's coving in the ST T wave configuration. So it comes down. Typically this looks like a fairly straight line, but there should be some coving or some slurring in that. And your ST segment is gradually descending. The differential here is that we still have an increased J wave of greater than 2 millimeters. We still have a negative T wave, but our ST segment is saddlebacked or camelbacked. And typically that's in V2 as opposed to V1. That's why lead placement, one of the reasons why precordial lead placement is so imperative, right? If we get V1 high and V2 high, we're not going to catch things like this, and it's going to look all womper-jawed. Typically, it's family history is sudden cardiac death or history of sudden cardiac death in the family at less than 45 years of age. There's a lot of times a history of syncope and a history of nocturnal agonal respiration, otherwise known as sleep apnea. Absolutely. Okay. So it's a bad thing. The risk of Brugada is sudden cardiac death or ventricular tachycardia. Good catches. Oof. This can really look like a really, really, really bad MI. Okay. If we have an ascending aortic aneurysm, and more importantly, if it involves the coronary os, the atrial, the pulmonary valve, oh my God, aortic valve, old man stuff, we can see dramatic changes in the EKG. If we look at this EKG here, look at this massive coving in V1. But I want to look at AVR. See the AVR, we don't see anything. But the rest of it, we have massive changes. So historically, they may complain of back pain. They may complain of a tearing sensation. They may have had a localized thoracic trauma, right? We put this on. This essentially is an MI because of lack of flow to the coronary vessels. Remember that our coronary vasculature gets perfused during diastole. So the heart pumps, ejects blood into the aorta, the aortic valve slams shut, we get some regurgitation back down through the coronary arteries. Well, if we look at this aorta and we have this ballooning, right, that's going to drop, we're going to have a dramatic drop in aortic pressure. Aortic pressure is what drives our coronary perfusion pressure. And if we think about it, depending upon how far up this goes, this is where we may see a change in pulse and or blood pressure from side to side in the radial artery. Okay, because this in here comes up and involves that right brachiocephalic trunk. So we're going to have a reduction in pressure across the left side. Does that all make sense? Hammering through some of this stuff so we can get to some cases. Prinz-Metals variant angina. So this is angina to the extreme. It's caused by typically a coronary artery spasm. We may have ST segment changes during the angina that typically go away without the pain. It does not look like, what's that syndrome that we talked about earlier? That was a STEMI equivalent. Was it Wayland's? Was it, we've talked about a whole bunch of stuff. What was it that was associated with chest pain, cessation of chest pain, and then ST segment changes in the precordial leads? Remember what that was? And it occurs during rest. No pain, but history of pain. Exactly. Okay. How do we treat this? It looks like a STEMI. It's not a STEMI. What happens if you call this a STEMI? If you look at the letter A, 12 lead EKG, would you call that a STEMI? Does it meet STEMI criteria? Oh my God. Yeah, kind of. A whole lot. I look at that EKG and I go, oh God, right? And you give him some nitro, like a good paramedic does, and you take another 12 lead, and that's what it looks like. And you go, oh, yeah, hey, ER, so,
What's worse?
yeah, it's bad. It's really bad. Okay, it typically does very well with nitrates. It's an unstable, whoops, sorry about that. It's an unstable anginal pattern. Okay. But it is transient. That's the key. Pulmonary embolism. I love these EKGs. Because remember, pulmonary embolism, you remember the waveform pattern that we see in pulmonary embolism? What's that magic? It was taught to you in paramedic school. S1Q3T3. Woo! What's that mean?
Joe loves this one.
Nothing. Zero. It means you look at a piece of paper and you see an S1Q3T3. Is it sensitive to pulmonary embolism? No. Can it be lead placement? Yes. Can it be axis deviation? Yes. How about S1Q3T3 with a right ventricular strain pattern? Now we're getting somewhere, right? So what is, we see, let me describe S1Q3T3. So in lead one, we have a prominent S wave. That is happening here. That's an absolute prominent S wave. It's very prominent. Q3, so go to lead 3. Is there a Q wave present? The answer is yes. And T3, well, what does T3 mean? That means a T wave abnormality in lead 3. So it's flipped, it's elevated, it's broad, right? It doesn't meet normal Q wave criteria. So that then describes that pattern of S1Q3T3. And that in and of itself is meaningless unless we have a right ventricular strain pattern. And a right ventricular strain pattern is most prominent in AVL, and that is ST segment depression in AVL. That in the presence is typically associated with a pulmonary embolism. But if we have enough pulmonary embolism in the lungs to make the right heart strain by pushing blood out against the pulmonary pressures, what would we also think is present in that EKG? They're compensating, so they're tachycardic. Okay. If you have an S1Q3T3 with a normal cardiac rate, it's still significant. Maybe they're compensating, maybe they're failing to compensate. Maybe they've already compensated and now they're unable to, and their heart rate is dropping, right? So S1Q3T3 with a right ventricular strain. Atrial tachycardias, you can have them all. They can be AFib, they can be a flutter, they may just be a sinus tach. Takotsubo's cardiomyopathy. So this is also known as broken heart syndrome. Typically occurs after a stressful event, maybe up to a couple of weeks after a stressful event. The last one that I saw, I've seen a couple of these in my career. The last one that I saw was actually a paramedic friend of mine who lost her husband in a fire incident. It was very dramatic, a very stressful situation. She started complaining of chest pain with syncope. And it was found that she had Takotsubo's cardiomyopathy. It's a stress-induced situation that typically is transient. And what happens is you get apical ballooning of the ventricle. It's a catecholamine surge that causes it. So you have an immediate acute ballooning in the ventricle. When that happens, it has the inability to squeeze enough. So we drop our cardiac output, we drop our blood pressure, we can have syncope and loss of consciousness. And then during the incident, we can have EKG changes such as this. Again, does this meet STEMI criteria? We absolutely have ST segment elevation in V1 through V5, right? We do have ST depression in lead 3, but that's all. So it does not meet STEMI criteria. But it looks like a massive anterior wall, doesn't it? We have dramatic ST elevation in V2 through V4. We look at that, we go, oh God, we alert. Not necessarily needs a cath lab. Cath lab's probably not going to do much for it. Probably do, hopefully, transesophageal echo and see that ballooning. What is the treatment for Takotsubo's cardiomyopathy? Time, stress management, and arguably benzos. Andra, can you kind of kick in here, like from the ER standpoint? Do you typically use sedative medications in this or catecholamine blunting medications?
Not regularly in the ER, but cardiology might, I don't know.
Okay. So what's your path in the ER for something such as this?
In a well-resourced hospital, we would reach out to cardiology. They'd get an echo. In a more rural setting, I think you'd call cardiology for transfer.
Perfect. That's awesome. This is probably going to be an interfacility transport. Okay. And in that realm, we have to manage blood pressures, right? We have to manage rates. It's symptomatic management. Okay. So left ventricular aneurysm, a recent MI, typically within about 2 weeks, can go upwards of 45 days. What we look for here is prolonged ST changes with a history of a recent MI. And that's significant of an LV aneurysm. What's a left ventricular aneurysm? So what happens when we have an MI, right? When we have that infarct and the tissue dies, it remodels, right? So it thins out. We're not getting enough blood supply. That muscle no longer contracts, and that can then become an aneurysm, much like Takotsubo's, right? Instead of that left ventricle contracting, it contracts around that dead tissue, that hypokinetic tissue, and it balloons it out. These can be devastating. Not much that we can do for it in the field. If they're big, this is a really bad thing for life-sustaining stuff, right? I mean, you got to have that left ventricle beating or you don't live. This may be the cause for putting somebody on a transplant list. This may be LVAD, Impella, right? The advanced stuff that we can't do. But us in the rural environment have a long way to go to get them to the place that they need to be. And the management of these can be quite sketchy. But it's really symptomatic management for what we can do. Okay. So recent history of an MI and seeing prolonged ST segment changes. Most likely going to be septal anterior stuff, can be lateralized depending upon where it's at, right? So based upon the geography of their MI initially as to what it is today. LVH, left ventricular hypertrophy. How do we look at an EKG and say they meet electrical voltage criteria for left ventricular hypertrophy? Count what? It's QRS amplitude, right?
Yeah, up to 35 and lead V5 and V6, correct?
Close. V1 or V2, the largest R wave of V1 or V2, plus the largest R wave of V5 and V6, add them to count them, add them together, and if it's greater than 35, you have LVH. Kind of a simpleton. I'm from the Sandhills, I'm high foreheaded, I'm redneck. If shit touches in the EKG, it's LVH, right? See what I'm saying? See where shit touches? That ain't supposed to happen. That's LVH, okay? Or you look at the numeric values that cardiac monitors are really good at assigning, and you add them. You ain't got to count nothing, okay? So what significance is LVH? Left ventricular hypertrophy.
It's the expansion of the left ventricle making the walls thinner.
Okay, or thicker, right?
Yes.
So what causes LVH? The number one cause, hypertension.
Yeah.
What happens when you go to the gym and you overwork a muscle? It strengthens it, doesn't it? It gets bigger. You get more strong. But the problem is in the heart, when that left ventricular wall gets thicker, what doesn't it do very well?
Your ejection fraction.
Ejection fraction drops, right? So cardiac output drops. So hypertension causes it. Systemic hypertension. Now, right ventricular hypertrophy is caused by pulmonary hypertension. Same concept, different side of the heart, okay? So LVH is a STEMI mimic because as much like in the Scarboza criteria with left bundles, we think about that conduction pathway going through that ventricular tissue. It takes more voltage to get through that thick tissue, right? We talked earlier about sensation, right? That atrial and ventricular contraction, that becomes altered. So we have a drop in cardiac output. Benign early repolarization. Well, there's a couple of things that really make this stand out. We see this ST elevation in more specifically V2 through arguably V5. We see it in 2, maybe not 3. We do in AVF, some in 3. We see a little bit in 1, not really in AVL. It's pretty widespread, isn't it? What's missing out of this EKG to make it meet STEMI criteria? There's indication, right? There's ST elevation. There's no reciprocation. There is no ST depression anywhere in this. There's no T wave inversion anywhere in this. And the other one is if you look at your ST segment, it is happy faced, right? It's convex or cave. It's convex, right? Concave ST segment elevation is what we're looking for in the presence of myocardial injury. Hypothermia, quick one about hypothermia. It can be anything. You can have ST elevation or not. One of the classic signs, if you look at this, is this Osborne wave right here. And it happens typically in the anterior leads of the precordial leads. We see it here in lead 2, arguably AVL, but it's a little bit more to differentiate. We see the QRS that has kind of a camelback, right? It's,
Someone's really interesting.
yeah. But over here in V3, that's an absolute Osborne wave. There are very few causes for Osborne waves, one being hypothermia. So how do we differentiate the other causes of Osborne waves versus the hypothermic patient? Don't overthink this. Yeah, they're cold. They're cold. And they got Osborne waves. Osborne waves confirms that they're cold. Them being cold confirms the Osborne waves. What's the potential problem with it? What do we know about cold patients? They're very susceptible to bradycardia and VFib. The more the Osborne wave happens, that's an irritable ventricle, right? The higher your risk for ventricular dysrhythmias are, VFib, okay? Obviously, any one of the bradyarrhythmias, AFib, junctionals, AV blocks, it goes all over, okay? So once again, OMI. If I've succeeded in one thing today, I hope it's that you look at STEMI a little bit different than when you started. You look at ST elevation MI and the criteria that's associated with that to say it catches a few, but it doesn't catch some really important stuff. And to kind of go down that rabbit hole, because this is where we can hopefully make a difference in our patient outcomes. And yeah, we got to take out what happens when they get to the ER, right, of our critical access facilities. But we can be the impetus to change of this. I would encourage you to Google the OMI manifesto and read through it. It's got some very, very, very good points in it. I don't want to belabor that a lot more, but I want to get into some cases and have some true clinical discussion. So we're going to take a 10-minute break. We'll come back. I have quite a few cases. We're in right up to 12 o'clock. If that's 2 cases or if that's 18 cases, we'll get there. I want to know, is it STEMI? Is it equivalent? Or is it a wannabe, a mimic, right? So take 10. We'll come back at 10:25 and we'll start case discussions. So here's the rule with cases. Everybody's got to hammer Dr. Farkas with chat because this is the classroom participation thing. Or conversely, you can certainly come off of mute and answer questions that may be asked verbally as well. It's kind of a lot to manage with this many folks, but this is where discussion comes in and helps. All right, here we go. Case number 1. If I can get shit to work. So because I can't do presentation mode, you get all of the details at the first. because this is all animated to come in and it's all cool. And I worked really hard to do it and can't do it. So here we go. 27-year-old female, palpitation, shortness of breath, 1 week. Advised patient seen by 2 at local urgent, ×2 at local urgent centers. No diagnosis or treatment provided. So what are your 5 differentials based upon your dispatch information? Don't read the other side of the screen yet. You haven't arrived until I arrive you. 5 differentials for this. 27-year-old, palpitation, shortness of breath, weak. See if I can get chat up here, because then I can.
Arrhythmia.
Anorrhythmia. I like it. Keep coming.
There's also a comment of pulmonary embolism and anxiety in the chat.
Okay. That's 3. Keep them coming, guys. All right. Now you arrive. We'll go with 3. Found sitting upright in the armchair, just awakened from a nap, feeling markedly short of breath, weak, anxious, slightly pale and diaphoretic, and you note increased work of breathing. Does that change your differentials? Yes, no? Maybe allergic reaction? Maybe sepsis? Pneumonia? Pneumonia? Right? Initial vitals, heart rate of 165, pressure of 125/99, a respiratory rate of 26, a room air saturation of 79, an end tidal of 29, and a Glasgow coma score of 15.
Definitely something part for lung related.
Something in here? Yeah, there's something in here. That's where we're at right now. What else do you want to see? It's an EKG class. I want to see an EKG. Duh. There's your EKG. What do you see? Talk it out. Think it out.
I'm guessing that's not good. Tachycardia, atrial tachycardia.
Is this a STEMI? Is it a STEMI equivalent? Oh, no. Now we got to apply what we learned in lecture. What?
It's not a great 12.
Okay, let me make it greater. Is that greater? So we see here it was interpreted as paroxysmal supraventricular tachycardia by paramedics on scene. They were unable to transmit it. Is this PSVT? Shake your head sideways. Coco sees, well, hey, Coco. Coco sees P waves. I agree. It's not PSVT. What is it? She sees P waves. She sees QRSs. Every QRS has a P, every P has a QRS. It's sinus tachycardia, isn't it?
Yeah.
So what are we thinking? What are your differentials? What's she need? Okay. How much? How? 60 liters, high flow nasal cana.
What are lung sounds on?
Clear.
15 liters.
Okay.
I'm not happy with 79%.
I'm not either.
So
We'll go ahead and cure that right now, right about now.
immediately looking at the 12 lead, nothing is like
Nothing stands out and
standing
goes,
out
oh
to me
God.
To say we need to treat this immediately. My greater concern is for oxygenation.
Absolutely. Oxygenation, oxygenation.
Is she
So you put her on
oxygen-
15 liters non-rebreather, that gets her up to a magic 85.
I know this. Good enough.
What are her lung sounds?
Lung sounds are essentially clear.
Well, since it's the EKG class, I feel like it's not predominantly pulmonary related and will predominantly be, it's been doing that the whole time.
Oh, has it?
Yeah,
Oh, I just noticed it.
we just wait till it comes back up.
That's cool. Okay. Should we give her adenosine?
Yeah,
They did.
I considered it. Yeah.
She died. This is an ACLS kill.
You have another one.
Now, how do we rate control? Well, when we look at something and we say it's tachycardic, tachycardia is the thinking man's dysrhythmia, right? What do we do to compensate for cardiac output for everything? What's the initial thing that our heart does? It speeds up, right? In order to preserve cardiac output, we increase our rate. Think of tachycardias as being compensatory for something. Do you have to act right now? What was her initial blood pressure?
125/99.
Yeah, 125/99. Nah. This is an actual case. Paramedics gave her adenosine. It worked. It slowed her heart rate
To zero.
to 0. And she died.
What was her temperature?
Temperature, she was normothermic. If we look really close at this, do we see an S1Q3T3?
She have a heavy block?
Anterior fascicle, right?
Yeah.
Historically, think about this. She's a young, healthy female who's been to 2 separate things, urgent cares, right? They haven't caught it, they haven't treated it. Now she's having crashing symptoms, so she calls 911. I think somebody said it, yeah, Steph Harms said pulmonary embolism. This is an ACLS kill. They did the right thing by ACLS to slow the rate. They gave her adenosine. They eliminated her cardiac ability to compensate for an underlying pathology. Be cautious with tachycardic rhythms. Make certain that they're not compensating for some sort of underlying pathology. It's very easy to go in and go, oh yeah, she's young and healthy. She's really tachycardic. Her blood pressure is fine, but we really need to rate control her before her blood pressure isn't fine. Travis was spot on. I'm sure some of the audience was spot on in getting oxygenation improved, right? If you put her on oxygen and she gets up to 88%, but her heart rate decreases by 10%, is that the problem? Shake your head this way. Yeah, we just haven't appreciated enough oxygen, right? That's where I would be then cautious to rate control this. Hell, maybe this is AFib with RVR. That's where we can get wrapped around the axles is we compensate by increasing rate, number one. So if we just immediately go in and rate control people, not thinking through the situation, we have at least blunted, if not inhibited, their compensatory response. Be thoughtful, right? Maybe their blood pressure is fine. If we're treating the oxygenation side of it, we put them on 15 liters by non-rebreather and that's not working. Does the blood pressure support CPAP? Maybe or maybe not. Think about other things, right? Before we immediately rate control something. Comments from the gallery on that one?
You're saying there was an interior block on it as well?
Yeah, which is probably rate dependent, right? So follow up. Base contact post Valsalva, they Valsalvator, then they adenosine, success, rate controlled to 0. Hospital arrest on arrival, undifferentiated ultrasound, differentials, obviously hypoxic respiratory failure, pulmonary embolism, and medication-induced tachydysrhythmia if she was given something, right? CPR, TPA ×2 to attempt to get rid of the pulmonary embolism. She postmortem had pulmonary embolism with the right lower extremity DVT. Rate control's cool. Not appropriate in all cases. Questions, comments on this? Absolutely. Absolutely.
What was the rate originally?
170, I think is what it was.
Did it have P waves in it?
Yep. It did. Sinus tach.
Why did
Sinus tach is a compensatory mechanism 100% of the time for something else.
Totally. Why did they do the adenosine there? If it
Well,
was
ACLS, I don't know. I wouldn't have.
huh? Sinus tach's not an indication. It's gotta be SVT, so that's like no P waves.
Well, that is SVT.
My understanding is that if it has P waves, it's not AV, RT, AV, NRT,
AVNRT.
whatever it is.
It's not one of the pre-excitation
AV,
syndromes.
CD, ERT, whatever it is.
Right. Can be
Um,
one of the other entities as long as it occurs above the ventricles. It's supraventricular tachycardia. Sinus tachycardia is still a supraventricular tachycardia. That's the reason we name these things.
Totally.
Okay, case 2. You're dispatched to a local primary care clinic for a 51-year-old female with EKG changes. Beautiful. En route, dispatch reports the patient is in for preoperative testing, denies complaint. What are 5 differentials? So she's in just to get a physical for a pre-surgical candidate. And she has EKG changes that cause the provider to call EMS. What are your differentials? Bradycardia, okay.
I wouldn't even venture a guess.
A STEMI.
STEMI, okay, we'll take that. Do silent MIs happen? Yeah, oh damn, yeah. AFib or another arrhythmia, okay. MI, I like these, okay. So she's found in the exam room, sitting upright in the chair. She's awaiting a carpal tunnel release, has felt generally weak over the last 3 to 4 days, and thought that it was her quote unquote blood pressure medication. So she quit taking it. She remains on all of her other medication. Medications are hydrochlorothiazide, potassium, and over-the-counter non-steroidal anti-inflammatory. She has no known allergies. Vital signs are heart rate 101, blood pressure is 101/60, respiratory rate of 16, and a room air SpO2 of 97. So what do you want? I want to see the EKG changes.
Can you zoom it?
Yo, I can zoom. I absolutely can.
You need to.
I what is this? Anybody? STEMI mimic, STEMI imposter, or STEMI?
Mimic.
Mimic, which one?
Hyper K.
Hyper K? What makes you say hyper K?
She's on a calcium or a potassium supplement and stop taking her potassium wasting diuretic. You also have the sine wave going on, peak T waves.
Are those peak T waves?
Yeah.
Uh-huh. Uh-huh. And she's got a very, very wide QRS duration.
Yeah.
What does she need right now?
She needs potassium right now.
Well,
But
Well, if she needs potassium, I mean,
albuterol.
if you gave her potassium, it would be diagnostic.
uh,
Yeah, it would go to a sine wave and you know where to start. Calcium out and albuterol, absolutely, right now. And
sodium bicarbonate.
maybe dialysis, right,
Yeah.
to get rid of the potassium, right? Okay, good. That was an easy case. So you give her calcium and her QRS complex narrows a bit and her T waves calm down a tad. Is that good?
It's better than getting worse.
And you have a 35-minute transport. What do you need to consider?
More calcium.
More calcium. Beautiful. You guys are on it.
We don't have enough in the truck.
Helicopters more.
That's what it was. Yep, absolutely. Hyperkalemia. Case 3, local community access hospital. Let me zoom in on this a little bit. IFT to a tertiary care about 2-hour transport, 61-year-old in STEMI. En route dispatch reports patient in POV about 3.5 hours ago. General complaint of weakness, denies ACS symptoms, no chest pain, shortness of breath. Reports uncomplicated ER admission, troponin bumped, prompting the need for an IFT. So you're taking this young individual for cardiovascular consult because their troponin hiccuped. Okay, cool. We do that all the time.
Mhm.
No EKG changes, but maybe some ischemia. That's what was reported. Documented history, type 2 diabetes, hyperlipidemia, takes Levemir, Simvastatin, Ozempic, has allergies to peanuts and hay fever. On arrival, you find them semi-reclined in bed, no apparent distress. Noted a 20-gauge IV in the left forehand that is a lock. Sending facility treated with 324 milligrams of aspirin and 4 milligrams of Zofran. Heart rate of 96, blood pressure 162/90, respiratory rate of 14, a room air saturation of 94%, and a GCS of 15. Thoughts? What are you taking? Well, an NSTEMI, because that's what you're taking.
Mhm.
It's what you were dispatched for,
Now it's
right? It's an NSTEMI. It doesn't meet STEMI criteria, so therefore the troponin bump, it's an NSTEMI, isn't it? Does it meet criteria for STEMI? Is it a STEMI equivalent, or a STEMI imposter?
STEMI equivalent.
Is a STEMI equivalent. Okay, either come off your mute or type into the chat what you think this STEMI equivalent is. From the room, what is this EKG?
That's posterior.
Isolated posterior?
I think so.
Boom, 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 boom. Absolutely. Thank you for the non-STEMI. Let's go ahead and get her on the bus and make the wheels on the bus go round and round. Can I have a Hepburn drip?
Yeah, there you go.
Pretty please,
Helicopter.
right? Yeah, absolutely.
I might ask for it. Boy, if I saw this on the EKG before we left, I might.
Meh.
This person
We
is-
take these all the time. It'll be all right until it's not.
I don't.
You'll be all right until it's not all right.
That's right. Grandma, go ahead and slide over here on my bed. Let's get moving, right? So, no, absolutely. So what are some of the things we think about with an isolated posterior wall MI? Like physiologic response. What are some of the problems we might need to manage in this 2-hour transport?
Ectopy, bradycardia, low BPs, cardiac arrest.
Kind of depends, doesn't it?
Yeah,
Is,
totally.
is it a right-sided heart involvement because it's posterior and all the anomalous changes in the vasculature and blah, 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 blah. Be ready for anything. This is a STEMI equivalent, right? Do you put the patches on?
Mhm.
Shake your head up and down. It's okay. In my small agency, I'll go ahead and spend $99 for a set of patches on this, right? To be ready. What if you don't use them? Great.
Then you
Cool.
don't use them.
They're
Then
the
you don't
Christmas
use 'em.
bonuses.
Yeah, absolutely. Do you think there's a potential of needing pressers? Maybe, right? So go ahead, get it out, get it ready. You don't, if it's epi push dose, you don't have to mix it up. Have it at hand, right? Do you think it might be an airway compromise problem? Do you think it might be an arrest situation? Yeah, it's all right. Go ahead and lay your stuff out and get prepared. Get prepared for the if this, then this situation. If you got to put all your shit back into the bag when you get there, cool. If you got to use it, it's right there. You cognitively unload, you prepare yourself for it, and when it happens, your ass ain't out in front of your feet. Okay? Yeah, there's Waldo. Case 4. You're dispatched to a local address for a 60, in the local address may mean 22 miles to us, right? For a sick patient. En route, dispatch reports a 4-day history of general malaise, unknown fever, no recent trauma, and he likes mustard on his biscuits. Good dispatchers. They're getting a good history. What 5 differentials? Yeah, what are your 5 differentials?
Sepsis.
Sepsis, I like that. Stroke,
Yeah.
okay, I like that.
Low blood sugar.
Low blood sugar, I like that. If anybody says COVID, you're fired. I'm done with that. Yeah. How about anybody thinking, let me see, 68? Just general malaise. Anybody think maybe a hypovolemic situation? How about in an EKG class, cardiac dysrhythmia? Maybe. Okay, so you find a confused male patient laying supine on a couch, head elevated. Wife reports that he's been feeling poorly times 4 to 5 days. He's just laying around. He became confused this morning. He takes Flomax and aspirin, 81 milligrams a day. Wife denies any knowledge of allergies. Current heart rate is 146. Blood pressure is 99/46. Has a respiratory rate of 22, a pulse ox of 94, and it doesn't say, but I'm going to put his temperature at 101.2. Needs a fluid bolus? Does he need a diesel bolus yet?
Oh, yeah, he's all obvious.
Yeah. Oh, you guys
Depends on how far.
are good. You put him on the monitor, and this is what you see. Do I need to zoom in on that?
Yeah.
Let me zoom in on that. It's multifocal atrial tachycardia, right?
No, it's a AFib RVR.
Okay. Anybody say anything other than AFib? I'm going to put my hat on AFib. So we see AFib on a 68-year-old. We're like, yeah, people live with that every day. Do you have a history of AFib? Did you notice he wasn't anticoagulated? Oh, he kind of was anticoagulated because he takes 81 milligrams of that. Is that AFib anticoagulation? You shake your head, no. Probably not. I would consider this possibly new onset. What would I want to do? Stroke assessment and get one of these.
Zoom it in again.
Do you see anything in there you don't like or don't expect?
There's some PVCs, there's compensatory pause, there's some.
But are they PVCs or are they premature?
The two that I am seeing, I would say, yeah.
Well, what's his
Look further to the-
intrinsic rate?
Well, you're looking at,
Yeah.
I'm seeing them in AVL, about halfway through it,
Yeah,
that rate would be tachycardic.
but he already is tachycardic, right? Look at his R, like the last two complexes or three complexes in lead three. He's already tachycardic. We have a heart rate of 146. Are those premature?
Yeah.
No, but they're still aberrantly conducted.
And if you look in lead two, about 3/4 of the way through, we'll have skips going on, or at least a pause.
Yeah, it's AFib, right? Alternating rate.
Big pause.
I don't like AFib with ventricular conduction issues. Right? Here's the deal. What do we think's going on with this guy?
He's probably got septic shock.
Yeah, right. AFib with RVR is really very common in sepsis. When I got septic shock, I was AFib RVR to rate 180s. And thank God that they didn't just rate control me, because that was compensatory rate. And that they recognized, oh God, and this is 10 years ago, so I was, well, 12 years ago, so I was even a little younger than what I am now, right? I didn't qualify for mature adult. So yeah, absolutely. Are you going to rate control this? Shake your head, no. What are you going to do for this then? Are you going to do anything for this rhythm?
Not for the rhythm, you're-
Okay, we're going to treat the patient's symptoms and hopefully improve their ability to compensate. How are we going to do that?
Predominantly fluids.
Okay, how much fluid? Do we need to support his blood pressure? It was 99/40, I think.
I'd start by like 500 volts. Go from there.
I'm good with that.
Have Levo on hand in case you need it. Have it pulled out.
Hell yeah.
Yeah. Have your pressors pulled? What pressors do you have?
Levo and push those epi.
You got Levo? Sweet. Like it. You got push dose epi? I'm gonna take your Levo away from you today. You don't,
We ran out.
yeah, you ran out of Levo.
It's not as much.
Travis wasn't on his job and it's all expired and it's all discolored and, so push dose epi?
Yeah.
Really? He's tachycardic.
Yeah, I wouldn't do that here.
I'd have it on hand. I wouldn't put the coin in.
No?
I would see at least what that 500 volts.
Absolutely. If it's the only pressure you got in the end to support it, I would certainly call in and go, okay, doc, this is all I've got. This is what's happening. What do you want to do?
Oh, what was the patient?
68. He's not in profound septic shock at this point in time.
Right. No,
Right.
but We don't need to make that heart work harder than it needs to.
Make that ventricular ectopy come together. That's cool. It's a diagnostic, right?
Just hit with the electricity.
I mean, it's only a couplet now, and then, 8 triplets, and then runs a VTAC. It looks cool on a monitor. Yeah, no. Okay, no, good. We're gonna increase his intravascular volume. And hopefully, how do we know by looking at the monitor, what's one surrogate by looking at the monitor that we're doing the right thing? Let's say we give him a 500 mil bolus. What are our expectations to happen if that's successful?
That blood pressure should go up and that heart rate should come down.
Absolutely. So tell me about the blood pressure coming up. What do we really hope for that? Do we think that the systolic's going to come up, or do we want diastolic to come up with intravascular volume replacement? I like the diastolic.
Yeah.
And then that will drive the systolic, right? And then hopefully that rate to come down a shade, right? Go from 140s to 130s. That's kind of success. We're not going to turn him around with 500. We're going to be like, okay, yeah, we're going down the right path. Let's give him another 500.
We're helping them along.
we're helping him a little, right? Is he gonna need more than 500?
Mhm.
Yeah, yeah,
A
absolutely.
lot more than what we-
What's the magic mathematical equation in sepsis?
Antibiotics.
20 mL per kg.
Oh, you're talking about that.
Times,
KG, right?
20 mL per kilogram
20 mils per kilogram,
over.
times 2 for an adult, times 3 for a kid, right? So he may or may not need more, right? Be careful not to fluid overload him, but expect that he'll require a fair amount of fluids. Okay. I like with his age, with AFib, with the acute onset of AFib, of doing smaller aliquots, working towards that magic 2 or 3 liters, right? But not just opening it up, 2 liters, sit on the bags like we used to, and make them bleed pink, right? Because that causes further things. Listen to lung sounds, absolutely monitor that, absolutely. Okay, questions, comments from the virtual folks? Case 5. Dispatch. You are dispatched to a local residence for a 54-year-old male complaining of generalized weakness and dizziness. Dispatch reports the patient began experiencing symptoms while doing yard work. What are your 5 differentials? Anaphylaxis.
Guess one is kind of, what's the temperature outside?
Atmospheric stuff, it's 72 degrees on a cool northeastern Colorado morning, bright and sunshiny, and no bees flying around.
I'd also say, like blood sugar issues. When was the last time I had anything to eat really good?
Okay,
Hydration.
Yep.
electrolyte stuff, I like it. Anything from the virtual crowd? So, hungover, that is perfect. Why are you doing yard work when you're hungover? So on arrival, you arrive to find the patient sitting on the front porch. He appears slightly diaphoretic, airway is intact and self-preserved, and he appears to be in minimal distress. He has a history of acute onset of dizziness with mowing the grass, reports a 2-day history of general weakness and quote unquote lack of energy. He denies any pertinent past medical history, takes ibuprofen once in a while, no known drug allergies, has a heart rate of 64, a blood pressure of 109/66, a respiratory rate of 16, and a room air SpO2 of 95%. What do you want to do?
BGL 12 lead.
BGL is 109. 12 lead is this. I mean, I know I'm working with an aged crowd here, so, oh, not that one. I want to move my mouse over here and do that one.
Elevation 3.
Yep.
ABL. Depression and ABL.
And 1, kind of 2. Well, maybe not. That looks like, well, see, it kind of looks like wandering baseline, lead 1. See how high the
Yeah,
T to P is compared to the T to P in the next.
yeah.
I'd say 2's your best bet. I wouldn't call on the other 2. 2 or AVF. Or 3's your best bet, rather.
What do you think in the virtual crowd? What is this, STEMI? STEMI equivalent or STEMI imposter? This is actually a really cool EKG.
STEMI equivalent.
I'm not seeing this one. I got inverted T's and AVL elevation in 3.
Does anybody say STEMI?
you say something? What are we missing?
Nobody says STEMI? Okay, I'll say STEMI.
Based
Why?
on- based
That
on-
or stimuli equivalent, it's pushing a STEMI though.
There's no push, it is.
There's elevation in the inferior leads.
There is. Look at 3. What do you think about AVF?
It depends on which QRS complex, I would say.
What QRS complex?
On the third one, I can see elevation. On the first two,
I see elevation in proportion to the QRS complex. If
oh,
you got a QRS complex, it's 1 millimeter.
mhm.
Yeah, I see a broad peaked hyperacute T wave in that. I see reciprocation in AVL, which is the most reciprocal lead, right? Questionably in 1, right? Although there is some wandering baseline, I do see some depression there. He's rate, the rate equates to an inferior wall MI as well. And also look at V2, guys. Does that look like carousel depression? Can you sit in that depression? Is that a saddle? Oh God. It's an inferior-posterior MI. Certainly it could be more profound.
I guess 2 is just no one, because it looks like it's pretty in line with that isometric line.
Yeah, that
Especially with
third,
that first QRS, maybe the second
the
one.
first and the third.
It does illustrate a very important point in EKG interpretation, and more importantly, in ST segment interpretation. Where do we truly measure ST segment elevation and depression?
The J point.
No,
Interesting. That's my training.
it is. That was mine too.
So where?
0.08 seconds past the J point. That's where your monitor, you get STJ, like in physios, it's measuring at 0.08 seconds past the J point. So if we do that, if we go 0.08 seconds past the J point into lead 2 here. Okay, so here's the J point, 0.08 seconds, we are 2 millimeters.
At least.
Yeah,
So if that's the standard, because
That's the standard.
I will change my medicine right here, right now. If that's the standard, then I agree with you. 100%.
it's another thing that the whole Dr. Smith OMI thing
Mhm.
came
Yes,
up on. It increases sensitivity.
understood.
Okay, because you're right. This EKG doesn't look all that bad,
Mhm.
right? Now, would I do serials? Absolutely.
Oh, yeah.
Right? Absolutely, I would be. I would expect this to evolve even more, but it still meets STEMI criteria. Andrea, agree or disagree? Coco, agree or disagree? I didn't see Coco come in. She's a physician too. Maybe we lost. Right, let's move on.
Agree.
Oh, I got an agree. Okay, boom, boom, shakalaka. Case 6. God, I gotta enlarge this from my old eyes. You're dispatched to a remote recreational area for a 22-year-old female acting strange. Woo! On-scene law enforcement, thank you, reports to you that they were called to the location for a loud party. While taking the individual into custody, they noted that she, quote unquote, packed something into her mouth and swallowed it. What are your 5 differentials?
Drugs.
Drugs,
Inebriation.
inebriation, intoxication, stroke, could be,
Schizophrenic.
schizophrenic, behavioral seizure. Oh, maybe hypoglycemia. Depends on what you poked in her mouth, right?
Mm.
You arrive to find a patient in a squad car in custody. She appears excited and somewhat agitated, but cooperative to your commands. See how nice I am? She denies any past medical history. She reports that she has no idea what you were doing here, quote unquote, because she didn't do anything. No medications, allergies to penicillin. That's cool. We're not going to give you any. Heart rate of 145, blood pressure of 168 over 100, respiratory rate of 22, SpO2 of 100% on room air. Skin is hot, pink, and diaphoretic. Peripheral pulses are palpable and bounding, and her temperature is 39.4 C or 103 F. What are you thinking?
Sympathomimetic poisoning.
Okay. Sympathomimetic. What kind?
Maybe ecstasy, because the increase in body temperature.
Pupils are 18 millimeters with no light. She's jacked up from the crack up. Does she want a hug? Oh, God. And this is an EKG class, so obviously you want to see an EKG. What do you see?
At a rate just under 150. Yeah.
Okay. Yes,
And
it's a wide QRS complex, isn't it? It's really tachycardic, isn't it? Remember we talked about sodium channel stuff? Cocaine's a very potent sodium channel block. So what do we need to give her? Adenosine? I mean, you can do anything you want. Adenosine is probably not indicated in this. What do we need to do with cocaine?
give it fluids.
Dilute.
Ah, the solution to pollution is dilution. I like that. Fluids. How do we get more sodium to a patient? Poor man sodium, right? Bicarb. The other AV nodal blocking agents that we typically use, or just nodal blocking agents, whether it's SA or AV, can be detrimental in this case. This is definitely a call in and saying, hey, this is what I got, right? What do we do? Some things would say sodium bicarbonate is indicated in this. I think it's probably the only thing that we carry that has anything to do with overloading the sodium channels that are being blocked by the agent. Is this a PUHA situation? You know what PUHA is? It's a very important medical acronym. Pick up, haul ass.
Oh, okay. I've never heard that.
Okay, PUHA. Yes, absolutely. Is she dying?
Right now. Go on. Depends on how much cocaine she.
Does she have a pulse?
Absolutely, absolutely. Treating symptoms, right? Okay, this is all jacked up because of the whole, we're gonna move past this one because that was a presentation that had all the animations in it. Case 7. Oh my God, we're getting there. You're dispatched to the local high school for a 17-year-old male just not feeling well. Dispatch reports nothing further. What are your differentials?
He has a test today.
He has a test today. Absolutely. Asthma, sick, 17-year-old, drama A. Oh, wait. Let's go back. You arrived to find a patient sitting on a chair in the school nurse's office. He came to the nurse's office complaining of just generally not feeling well after PE. Has no current medications, no known drug allergies, got a heart rate of 56, a blood pressure of 116/60, a respiratory rate of 16, and a room air saturation of 96%. Got good peripheral pulses and a good temp
That's his heart rate after.
after PE.
Okay.
And there you go. What is it? Is it a STEMI, STEMI mimic, or STEMI equivalent?
Minute,
Mimic?
I think so.
Guys, type in the chat or unmute. Let's talk. I get a mimic,
STEMI.
STEMI,
Really?
mimic.
Track with the mimic.
Everybody in here stick a mimic or going STEMI or going equivalent? Come on, hang your hat on something. Step up there.
Textbook.
Justin says early recall.
Textbook.
Mimics? Okay, so from the virtual side, those of you saying mimic, which one is it? And those of you from the in-class side, which one is it? Keep it to yourself for now. Which one? Okay, so I've got quite a few in the virtual side that say something. What say you, class?
Benign early repol.
Benign early repolarization? Don't even need to discuss any more on that. It's benign early repol. Why?
It's common in young males. And then you have just a classic slurring of the ST segment with the concave.
Absolutely. And it's widespread, right? Not isolated. We talked about that with that. That's good. Case 8. You're dispatched to the local dollar store, that's one of 7, for a complaint of chest pain. No further information as the RP hung up and they cannot regain contact. All right. So what are you thinking? Chest pain. Not even an age or gender.
Heart attack for sure.
And China.
Yeah.
A STEMI.
Sammy,
Are they worked up?
worked up, anxious.
Angina. Maybe you got hit in the chest.
There's a lot of stuff that
Angina,
you-
trauma.
We've already given
Could,
them 30.
it could be transverse flatulitis.
How about hyped up on drugs?
Drugs. Y'all know what transverse flatulitis is, don't you? I'll tell you offline. Yeah, good. We're getting there. On arrival, you find a 65-year-old male patient continuing their shopping prowess, appears in no apparent distress, but requests being quote unquote checked out. Medications, he says, no, I'm healthy as a horse. Allergies, I'm allergic to fighting with my wife. It leaves bruises on me. Vital signs, initial heart rate of 65, blood pressure of 141/90, respiratory rate of 16, and a room air saturation of 94. Skin's warm, pink, and dry. Peripheral pulses are good, and temperature's okay. He's a little warm. So he wants to be checked out. What do? You're the medic.
Ask him why he called.
I didn't. The wife did. She's out in the car because I ain't fighting with her. Well, I don't know if I want to go to the hospital, but I want to be checked out. What do you think?
Right now, I'm not worried about this guy at all.
No?
No.
I guess ask the dollar store person why they.
We didn't. The wife did. She's out in the car.
They're probably fighting.
So
They're
is it-
fighting.
Is it possibly her that's having the issue?
Good.
Does he actually have chest pain?
Yeah, a little bit.
Wow.
Yeah, I got a little bit.
Okay, is he like farmer rancher?
He's
Tolerate a lot of
65.
pain? Can he tolerate a lot of pain?
Well, yeah. I mean, pain's weakness leaving your body.
It's chest pain, automatic 12 lead.
Oh, okay. There you go. Chest pain's kind of gone now, but it hurt for a bit. STEMI, STEMI mimic, or STEMI imposter?
Stimmy.
Look like, but not.
That it ain't that.
No, so
STEMI equivalent?
Equivalent. That's the one I was.
Oh, okay. What is it then?
Welland syndrome?
Type A or B?
Ah,
Depends. Whether you look at V2 or V3. Is this Wayland's? Shake your head up and down. Right? Depends, right? Type A is V2, type B is V3. So what's the difference? Time. Right? Absolutely. Do you need to go to the hospital?
Absolutely.
Yes, it's a STEMI equivalent. Absolutely needs to go in. And hopefully, they do the normal or appropriate diagnostics and get this guy out because he is having some coronary vascular issues. Case 9. You're dispatched to a 38-year-old male, shortness of breath. They further report that patient describes about 4 hours of shortness of breath that is getting worse. What are your 5 differentials?
Allergic reaction, bronchospasm. Chemical exposure.
PE I have over here, chemical exposure, allergic reaction, bronchospasm.
MI, of course.
And a 38-year-old?
Hell yeah.
Okay, it happens. What do you want to do? What do you want to see?
Vitals 12 weeks.
Vitals, heart rate 102, blood pressure 80/50, respiratory rate of 26, a room air saturation of 94. It ain't staying that way for long. Warm, pink, and slightly diaphoretic, little diminished peripheral pulses, and a normal temp. Does that change your differential?
someone in that 12 weeks, someone starting 90.
All right, here we go. What do you think about that? Hell, I don't know what I think about that. Let's look at this. Whoop. Is it a STEMI, STEMI mimic, or STEMI equivalent? It's kind of a tough one, isn't it?
It's just hard to see.
There's nothing that stands up and really says, oh my God.
Well, I'm really concerned. I think. What, does this have the?
Yeah,
S1 QT3?
So this is
Nope.
a post-
maybe.
A little bit. I was looking at that myself because the axis deviation,
Yeah,
but that
the R wave protection's not like super high.
the peak time.
Or yeah, P time, sorry. Does it matter that the P waves are kind of pointy instead of round?
Kind of does, doesn't it?
It kind of does.
What do we call that? P pulmonale. It's a strain, pulmonary strain. So where are you going to this?
I want to call it PE. I really do.
Well, let me see. Let's go back one slide.
I mean, our SATs are good.
Are they?
The problem with it is you have decent stats, but you have this heart rate
That's
with
high,
the
low blood pressure.
blood. Yeah, exactly.
Got a
So-
high heart rate, got a low blood pressure,
Confidence.
got a high ventilatory rate,
Mhm.
and only satting 94% with a ventilatory rate that high. Oops. Wouldn't you expect your saturation to be higher with a ventilatory rate of 26?
Yeah.
Yeah, absolutely. I agree with you. This is likely a PE, although it does not meet S1Q3T3 with right ventricular strain. There are some indications of right pulmonary pressure, right, being the P pulmonale, but clinically this correlates. Is this an emergency?
Oh yeah.
Get a capno. Your capno is 24.
Not good.
Shit.
Yeah.
He's got bad pulmonary stuff going on. No, I agree. It's great clinical thought process. What did I do there? Okay. Dispatched to a remote ranch location for a 56-year-old complaint of severe chest pain accompanied by shortness of breath. Dispatch reports, I said male, female, reports that she is in a large barn to the south of the residence.
I mean, was she kicked? Do we have an allergy?
Yeah, 5 differentials are all it.
You're in a barn, yeah.
Yeah. All of it, right? Yeah, absolutely. You find her sitting on a bale of hay. She appears alert, airways intact and self-preserved, appears to be in significant amount of pain, clutching her chest. She reports a history of well-controlled hypertension, takes hydrochlorothiazide, atenolol, and 81 milligram of aspirin, has no known allergies, a heart rate of 102, a blood pressure of 80/50, a respiratory rate of 26, and an SpO2 of 94. I kind of think I did. Just because I'm cool like that. I knew what you were going to say. STEMI equivalent or STEMI imposter? Or nothing.
It's not the way that.
Hey,
What are
nothing.
the lines? Again?
Here, let me blow that up for you.
Inferior elevation. In lead two, you got ST elevation.
Hmm?
Interior, posterior.
What are we seeing?
Oh, no, I'm just talking to myself right now. I was just talking to myself.
So we have elevation in 2, 3 AVF being the inferior side. We have reciprocation in the high lateral leads, AVL in 1. And we got that funky depression in The septal anterior. Is that carousel depression or saddle depression? Does it look like you can sit in there and ride the pony? Huh? So this is what?
I think this is inferior posterior.
This is an inferior posterior MI. Good. Let me see what happens. Oh, look what I did there. During transport, the patient exclaims, I don't feel well. You look at your monitor and notice a change. What are your next steps?
Oh, God.
God.
Drive faster.
God, it's me.
Have to get slapped on.
You should have had them on before. You already said MI, right? MI pads on. Right? Because then when this comes, you can go, oh, damn it, grandma. You shouldn't have done that. Now you're going to get Edison therapy. Right? But here's some Versed, because I'm a nice guy and it's going to hurt. Or fentanyl. Right?
Let's just do both.
Yeah, absolutely. Is she extending her MI in front of your face? Absolutely. And this is a real concern with posterior MIs.
This is where that rectal.
Yeah, when she says, I don't feel well, you hear this? Right? How about atropine in this?
No.
Why not? What is this rhythm?
Looks like either a second degree type 1 or a third degree.
I'm going with a third degree. I just don't think there's drop QRSs in this.
I was going to say, where's your block?
Third degree.
Why do you say third degree? I say second degree type 1.
Always regular, always slow, widening, QRS, and they're tombstoning.
You look at like AVF and D5 right there next to each other. That third QRS, you have a P wave, missing QRS, another P wave.
Yeah, but look how regular it is. You need the compensatory pause. If you're going to drop a QRS, it's bang, 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 bang.
That's true.
And I also think there's a hidden P wave in the second QRS of lead 2.
And while you're determining this, her blood pressure goes to 50/20. It don't make any damn difference if it's complete or incomplete or partially complete or complete of the complete of the complete. You got to do something here, right? What are you going to do?
Pads and some new pants.
I don't think atropine works on a third degree, so not.
What's the determination?
How do you mean?
How do you know if atropine's going to work?
Try it, I guess. I don't know.
When will it work? If it's an infrahition block, right? If the QRS is not wide, it has a greater affinity to work. So what?
Okay.
Are you wrong at doing atropine while you're getting the pads on? Probably not. Does she need paste? Yep.
Ace, electric.
Yep. Ride the Edison wave. Yeah, atropine, if you got it right with you. Yeah, okay, so what? She needs paste. Is this complete or second degree type 1 or type 2? Yeah, sure. Truly, it's probably complete because of dissociation to the P-waves. Okay. Questions, comments, agree, disagree? Time's up. Is your P2P regular? Yes. You don't see them all because they're buried in the QRS, right? Is your R to R regular? Uh-huh. Okay. Complete. Probably third degree. Put that in front of 12 cardiologists, you get 17 answers. Case 11. You're dispatched to an approximately 22 miles from town to the highway for a party who pulled over in their car. There's a 49-year-old female can't get, well, that's problematic. It's a 49-year-old female that can't get his breath.
Very modern.
It was late.
Very modern deal here.
Dispatch reports that the patient's also complaining of chest pain and feels extremely weak. What are your 5 differentials?
MI,
MI,
PE,
PE,
anxiety.
anxiety,
49-year-old female who can't get this, but
right.
We're halfway between Denver and here, so.
So like in all seriousness of that, if that was the case, you'd have to think about hormone therapy as well, right? And that does cause some potential problems, right? If they're in transition. Okay, sitting upright in the driver's seat, anxious, alert, airway intact, and self-preserve. Denies any personal history. Report his father and 1 other brother died in their mid-50s from an apparent heart attack. Has no current medications, no known drug allergies, got a heart rate in the 150s, pressure of 112/48, respiratory rate of 19, and a room air sat of 95. Slightly cool, slightly pale, slightly diaphoretic, good peripheral pulses, temps okay. So you do the thing. What do you see here?
ATAC.
I'm gonna call it sinus tach.
Fair enough. I can see it.
I see a P wave before every QRS in 1,
No doubt about it.
V1, V2,
Mm-hmm.
AVL if you look hard, lead 3,
Yeah.
it's sinus tach.
No doubt about it.
STEMI, STEMI equivalent or STEMI imposter?
I just want to say.
Why?
Everything's increased.
Well, it's way pissed. It is. You're absolutely right. Look at AVR. Go back to that slide.
Down.
Is there ST elevation in AVR?
Yeah.
Next thing we look for is what?
Depression in 5 and 6,
Mm-hmm.
and you got it.
Mm-hmm.
So this is an equivalent.
Hold on.
This is an equivalent. This is a really, really, really bad equivalent. This is a left main coronary artery lesion,
Not familiar.
like above the LAD bifurcation. This is the entire left main. Why is he tachycardic?
Trying to get
Reduce.
more blood.
Yeah, absolutely. He's in a compensatory rate.
Oh,
He's got a sick left ventricle.
So you look at AVR and B5, B6.
Yep, and more importantly, the precordials. He's elevated because it's extending. Okay. I wouldn't expect him honestly to have a blood pressure that high. And if it is that high, it's probably not staying very long. Right? It's a classic example of a left main coronary artery or 3 vessel disease. 3 vessel disease you can see more importantly in the aged, not necessarily elderly. This is a young man, wasn't it? 22-year-old. Yeah. So this is bad. Is this a PUHA?
Yeah.
Yeah, absolutely. Okay. We're gonna do one more. Your dispatch of local residents for a 68-year-old male, nausea and vomiting. No further dispatch information. What could it be?
68-year-old nausea and vomiting. Food bug.
Could be one of, oh my God,
Yeah.
right? What do we know we're gonna do? We're gonna do all of our diagnostic capability, right? You arrive at the residence, find a patient sitting outside the residence on the porch. It appears as though they're vomiting into a trash can. Perfect. History of present illness, past medical history, reports history of type 2 diabetes, hypertension, and quote unquote, some sort of a heart thing. Perfect. Some more. Medications, Victoza, sliding scale insulin, lisinopril, amlodipine, and aspirin. Allergies, some blood pressure pill. Perfect.
Before we even get it, he's getting an IV, a bunch of probiotics.
You're not coming to my ambulance puking out. I don't care if you're dying, right? Yeah.
Maybe a little for me.
Heart rate 68, blood pressure of 154 over 102, a respiratory rate of 18, and a room air saturation of 95%. What do you want? There it is. STEMI, STEMI equivalent, STEMI imposter. Come on, virtual guys. What's the underlying rhythm? The sinus
Yeah.
with,
WPW.
no,
Make it bigger, Steve, so we can see it.
okay.
That's what it looks like in what would it lead to? See it slurring right there?
It's wide.
Okay.
I don't know if I'd necessarily call that a delta wave.
Okay.
I see what you're seeing, but more importantly, what's V1?
LVD.
The left bundle. So I'm getting STEMI, I'm getting mimic. PR is normal, so not WPW. Bingo. That rules out the delta wave,
Okay.
right? So left bundle. What do we do in left bundles?
I'm going with
Yeah.
Okay, so you're gonna have to identify it
I'm gonna call it a
because it's left bundle. What do we use?
enterolateral. It's because I got the concordant LST elevation in V4, and then V2 has enough, from what I can see.
What about lead 2? Lead 3 is ST depression discordant. There's rule 1, rule 2, and rule 3 of Scarboza, right?
Yeah. So it's
Remember, the Smith modification is greater than 25% of the R wave.
if it's
Look at V3,
disconcordant, right?
huh? If it's
discordant,
discordant ST elevation.
it's 3. Yeah, that's what that
That's almost half.
Yeah, V2, V3, and
It's
then
positive.
yeah.
You're absolutely right. So there's a sinus rhythm with a left bundle branch block that is Scarboza positive. That then is a STEMI.
Yeah.
Nice.
No doubt about it.
All right, kids. I have many cases. Hopefully you got a little something out of this. I want you to leave with this. What we use, whether it's Zoe, Physio, Tempest, Phillips, who cares? That cardiac monitor means something other than a check box on our run form. Look at every piece of clinical data that machine provides us with. Look at 12 leads a little bit differently. Understand that STEMI criteria is old. It still works, right? But understand that we miss some very important things utilizing STEMI criteria. And I'm not even talking about from the standpoint of alerting and getting PCIs going and, right? What I'm talking about is getting those patients from point A to point B, whether that's in the 911 environment to a critical access facility, or whether that's a critical access facility to tertiary care and or PCI. Understand that that little printout on that piece of paper gives us a lot of clinical information. Be comfortable with it. If you're not, go down that rabbit hole. Have the personal accountability to reach out there. There's so many resources available online. Dr. Smith, who wrote
Mhm.
the OMI manifesto, has a phenomenal blog on cardiology, on different cases. Scott Weingart, same thing, right? And they collaborated on the OMI manifesto. There are so many resources out there. Understand that even something as simple as looking at the vital signs and correlating them, going back to our last PE guy, right? It wasn't a slam dunk EKG, but what made that EKG correlate was the fact that he was hypoxic secondary to what would be expected, a respiratory rate of 26 and a SAT of only 94 and tachycardic and hypotension. See, that correlates. It wasn't that magic S1Q3 T3 and a big right ventricular strain. And oh my God, it was a simple sinus tach. But you correlate it and develop that clinical picture. Take all of the diagnostic criteria that we can, that we have, and correlate that to the patient. It will improve our outcomes. Then we fight the battle of changing nomenclature and habit within healthcare, STEMI to OMI, and one day, hopefully while I'm still alive and not on Social Security, God, that's gotta hurry up. Not on Social Security, we'll be able to move into that direction, and it'll be an OMI alert instead of a STEMI alert, right?
Mhm.
And we'll do better for our patients. What we can manage is what we do. We can't manage what anybody else or they do, right? We can certainly manage what we do. I appreciate the ability to come and do this. I love teaching this. If anybody, just reach out. My email is on the list. If you don't have my contact, call Travis. He'll give it to you. Call Andra. She'll give it to you. I don't care. I love doing this.